Great. Hi guys, here with Ron Myers from the Consulting Room and Medicine.
Hi Adrian.
Thanks a lot for coming along.
My pleasure.
First time in Prince's Rosemary?
It's been a while actually since we last met here, so yeah.
So Ron, just a bit of background. I've known Ron, how long have I known you, Ron?
Probably about 15 years I think.
Yeah. Long time.
It's a long time.
I know. I think Ron's perhaps aged a bit better than me, but you've been in the industry for 25 years.
I have, yeah.
And director of the Consulting Room,
yes.
and Medicine.
And Medicine, yes, a clinic. Yeah.
So just tell us a little bit about both of those.
Okay, yeah, well, I mean, my involvement in the industry began in 1994 when I was working for Allergan and just happened to be involved in the launch of Botox. So I go back a long way, and that was really, I guess, probably the start of the non-surgical, I call it a revolution really, and it has been a revolution since then. So, and it started slowly, but then probably in the late 90s, especially with the advent of lasers coming into the marketplace for hair removal and tattoo removal, kind of the concept of what we call now a non-surgical medical aesthetic clinic starts to come to the fore.
Yeah.
And then has built from there, and then various other suppliers have come into the industry with different concepts that can fit potentially into a medically led business model, and hence now we have clinics, or even what we call super clinics, that can employ even 10 to 15 people, have multiple locations, and have 20 or 30 different services that they have on their menu. So
back in 1994, Ron,
yes,
when Botox was launched,
yes,
there were not very many clinics in the UK, were there?
There were none.
There were none, yeah.
No.
So since then, it's been a really rapid.
A huge expansion, yeah, and it's been really interesting to see how that's evolved, and that's happened around the world as well. But obviously, in different marketplaces, like in the US, for instance, the people that embraced the non-surgical were already involved with private clinics. So that would have been plastic surgery-led clinics who would have been doing cosmetic surgery, like yourself, and it would have been dermatologists who would have been involved in disease dermatology that then embraced injectable treatments. Whereas here, obviously, with the NHS, it was a slightly different scenario, and so if you look at the number of privately led medical clinics, it's exploded.
Yes.
And that has provided opportunities for them to get involved in all these different aspects of private aesthetic treatments, as well as, to some extent, some private medical treatments that the NHS is not doing now that could fit into an aesthetic clinic. Yeah, absolutely.
So for a lot of our previous delegates, a lot of delegates watching this, setting up in the aesthetics industry, quite relatively new to it. So maybe you have a GP background, nursing background, NHS background, dental background. Mm-hmm. So what are the options? Where do you, so people can set up in salons, they can work from home, they can set up a clinic, they can work for a bigger organisation.
Absolutely.
Can you just run through the pros? Let's start off with home.
Okay. And some people do, and some people have established more than just a small room in their home. They've kind of put together an extension, if you see what I mean, around their home, and that's fine if it's feasible. And also, if you want to have your business operating from the same place that you operate your home from. So there's obviously pros and cons there. Probably the biggest con eventually, ultimately, if you decide you want to sell that business, it becomes a lot more difficult. Yeah, because obviously then you're into relocation. Yeah.
Are people selling businesses? Is that something that
they are now? I mean, I've known people who started off 20 years ago, who are in their 40s, who are now in their 60s, who are going, well, maybe I want to realise, the investment and time and effort I put into growing a business, and ease off and do something else. Mm. And there are different options, and it depends on the structure of their business and how much it depends on them, I think, is the critical part. Yeah. So there are big businesses, big corporations that are buying other businesses, for sure, and companies like Skin are. Yeah.
So we've obviously been through that because we did sell one of our business to
Absolutely, you have that experience.
Yeah. So how are businesses valued? They're valued on EBITDA. Can you explain what EBITDA is to our...
Well, it's it's an accounting term, and it's basically earnings before interest and tax deducted and amortised. So
that's right, well done.
and in essence, I mean, probably what most people would look at is profit of some form or another. It's just a slightly fancier version of that. So ultimately, if you look at your accounts at the end of the year, you will have a net profit that's after tax. And in general, most businesses are valued anywhere between 3 to 5 times the multiple of that net profit. The key consideration really is that net profit and how real it is, if you see what I mean.
Yes.
And within our industry, it generally depends on how much money that business owner is taking out as personal salary, as you know. So
just to be absolutely clear about this, because it causes a bit of confusion, if you have a clinic, let's say it turns over £500,000 a year, and your profit for that clinic would be roughly...
Well, let's say 10% net, 50,000, you know.
50,000. Now the question is, does that 50,000 include your salary?
Correct.
Okay, so the EBITDA is after your salary, so it's the total profit of the clinic. So let's say you turned over 500,000.
Yeah.
Your profit would probably be more than...
It should be.
It should be. So your overall EBITDA might be 10%. That's the money at the end of the business that's kept in the business after you've paid yourself. Yeah. And your clinic will be valued at 3
to 5. I mean, it's in service-orientated business, it tends to be a little less. And the key consideration is obviously, I mean, and generally, as you know as well, if somebody's going to buy into you and your concept, and you also produce a lot of the earnings, eventually they've got to replace you. Yeah. And generally, and I know, funny enough, a dermatologist who's just gone through this at the moment with skin, who they wanted him to keep in for 3 years, which is quite a considerable period of time, while they go through this handover period of basically him making sure that he hands over all of his patients to another experienced injector. So it's very difficult to exit just when you get the money, and often there's an earn out to that as well, potentially. So you won't get all the money that you've agreed up front. But you know, that's one option. The other option is, and some people are doing this as well, is what they're doing. They are gradually replacing themselves in their business with other people who come in and do the treatments. And so they are really a CEO type role, and they've extracted themselves totally. They don't earn the income in the business, they manage and run it.
So they work in the business, not sort of...
Well, they work on the
business, not in the business.
Correct. You're much likely to have a high valuation for the business and be able to extract yourself a lot quicker, normally within 6 to 12 months. But all of those things, I guess, eventually are, depending on your audience and looking at what you intend to do. With some people, this will be something where they're perfectly happy doing what they're doing within the National Health Service, but want something that's either a little bit more interesting and slightly different from a point of view of looking at their skill set and looking at what they can achieve with injectables, and obviously earning extra income from a private point of view. And for other people, they will be looking at this and going, actually, I want my career to eventually be entirely in aesthetics.
And some people may want to be more clinical. You know, some people say, look, I'm clinical, I want to remain clinical. Some people are more interested in the business side of things.
Correct. And so ultimately you've got to look at your skill set and what you want to do. And for some people, and this is how what we did with our clinic, we partnered with a very good clinician who was a GP, who initially started off back in the 90s when he learned injectables going around beauty salons, as people still do now. And then eventually when clinics like Courthouse Clinic and Laser Care, as they were, or now Skin, came to the fore, and you know, he decided really he wanted to have his own place, and instead of him going to these salons, he wanted people to come to him. But he didn't really have the skill set or ability to do that.
This is your this is the doctor you work with. This is the clinician. So exactly the same guys happened to me. I'm basically a plastic surgeon. I'm not really not a businessman. Am I a businessman, Ron?
Well, look, I mean, you have a greater awareness of a business than most people, and the key thing really is understanding the language of business, but then being it's the implementation that's the problem, and you can't be in theatre and coordinate building a website or bring in staff or find a premises or all those other things, and that's the key thing. If you can find someone that can manage the business element of it, and that's quite broad skill set, but build that and run it, and then you go in and basically do what you enjoy most. And with your skill set, because of course your learning and skill set as well revolves around still learning and keeping ahead of the game in terms of surgical techniques, and you can't do that and keep ahead of the game with social media and business skills and marketing at the same time. It's very difficult. So you can form a relationship with someone who can do that.
So I think Ron and I would agree. So essentially, I ran my own business and did the clinical stuff as well.
Yeah.
But I wasn't really doing it very well. The HR, the tax, all those marketing issues. So I then teamed up with a businessman. And you've got to remember, businessmen have really, you shouldn't underestimate the skills of a business person. And I think, would you agree that clinicians are very good at the clinical side?
Absolutely, yeah.
But they don't have much knowledge of the business side.
No, and running a business, if you look at cold, hard facts around businesses and people starting off businesses, they're not great in terms of survival rates. Most businesses don't survive 10 years. No. 90% don't. Yeah. And those are people often
with aesthetic businesses or just general?
Just across the board, generally across the board. And so, you need to understand the language of business to have half a chance of being able to put those statistics in your favour.
Yeah.
And a lot of it, I think, revolves around, probably having a clear strategy and a clear focus and a clear understanding of numbers and how they work in a business.
Absolutely. So moving on, so we started a little bit talking about working from home.
Yes.
What legislation, D2, could you tell us a little bit about what you need, CQC?
Well, in essence, if we're just looking at injectables for cosmetic purposes, as you know, in England at least, there are no real regulations around this, and people do operate from home without D2, and they go into other premises like salons, for instance, that aren't D2 registered.
Can you just tell people what D2 is?
It's basically being registered for offering medical advice and treatments.
Yeah.
And as you know, if you're going to do anything from a surgical point of view, you have to be registered with the Care Quality Commission.
Yeah.
So that's slightly different. In Wales, where I live, if you're operating lasers, any form of laser, you have to be registered with the Healthcare Inspectorate of Wales, which is the equivalent of the Care Quality Commission.
Yeah.
And here in England, they deregulated that. So again, alongside injectables, you can operate pretty much any aesthetic treatment without any form of regulation.
So lasers?
Any laser.
So just to be absolutely clear, you do not need to be CQC registered.
Not in England.
Not in England. No. But Wales and Scotland?
Wales is different. Scotland is slightly different again. Yeah. And so although it's not formal regulation, there is sort of more of a kind of a combined self-regulation body around Scotland, and it's because I don't live in Scotland, it's not something that, but there appears to be a two-tier angle to that. If you are a medic operating a cosmetic clinic, you need to be regulated.
Yeah.
If you're going into a beauty salon as a medic, as far as I understand,
this
you
is
don't
Scotland.
need to be. This is Scotland, this is Scotland.
Yeah.
So it is confusing, and I think you do need to understand that. But if you want to incorporate in, for instance, things like slimming services, which would fit in, and if you want to offer, for instance, liraglutide, liraglutide. So this is
to remind me what
it's a treatment for diabetes. It's something that some people may have heard of as, in inverted commas, the skinny jab, which is not a trade name and not a brand name.
But this is relative to who markets lipo?
It's Novo Nordisk that actually has that, but you will find aesthetic clinics that will be incorporating that as part and parcel of their business model. So they'll be providing weight management services.
Okay, so do you do the skinny jab?
We don't, no. But oddly enough, David, our doctor who works with us in his private GP clinic that he operates, does.
Yeah.
And he will offer hormones as well for menopause. And so once you start to get into...
Just to be a little bit clear, that's detailed analysis, isn't it? Bioidentical hormones. So not just general hormones, you're tested very specifically for which treatments would benefit you. Well, so there's lots of different options you can go into. I suppose most of our delegates would be focusing more on the toxins and the fillers to start off with.
Correct.
So if you were starting in the industry now, and you principally you've been trained and you're confident on fillers and toxins, what would be your sort of roadmap, do you think? How would you move forward?
Well, for me, there's kind of two different routes, and it depends on whether you just want to run and operate that business yourself, i.e. just develop and extend the services that you offer personally, or whether you want to incorporate other people into your business who will offer other services. So generally the traditional model now, and the one we operate in our clinic, is having our injector who just focuses on injectables.
Your clinician?
Our clinician, yeah, and he loves that and he's very good at it.
Yeah. And
total facial contouring as a concept, being able to reshape a face with toxins and fillers at that advanced level is appealing and is certainly profitable if you can bring in the right people.
And so, roughly, patients he sees,
yes.
How long does he see them for, and what would the average patient be having? Toxins, fillers, and what would the cost of that treatment be?
And it will vary. So for us, for instance, for one area of toxin, if somebody comes in, we give them a half-hour free consultation for us. Yeah. Well, actually, we do have within our clinic now, for our doctor, we'll charge £75 for a consultation.
With your...
Yeah, but that will be reimbursable if they go on and have a treatment.
Okay. So let's say I'm coming to see you.
Yes.
So I phone Medizen.
Yeah.
Who will I talk to first?
You'll talk to receptionists.
Yeah.
So obviously your receptionist and their level of training and understanding around especially your price points is important for us because we charge 235 for one area.
Yeah.
And in Birmingham we have non-medical people who are charging £60-70.
Yes.
So what we have to do is to credential our clinic and how we operate so that people understand why they might be paying £235.
So if I phone you up, Ron, is your receptionist going to say, she's going to tell me, will she discuss finances there and then?
She won't. If somebody just wants to book an appointment, that's fine. We just take the appointment, look at the right, trying to get the most convenient time for that individual within our...
So I phone you up,
she'll
give me lots of information,
yeah,
fit me in.
Yeah.
How much will that appointment cost me?
£75.
Okay.
Yeah.
How do I pay that?
Via a credit or debit card over the phone.
Okay.
Yeah.
Do people have qualms about?
They do indeed, but from our point of view, because we value our practitioners' time and because I guess we're a little bit more sophisticated in with our presence in the market, we feel that way it pretty much guarantees that the patient will arrive. If you don't charge anything, you can't guarantee that.
Yeah. What percentage of people do you think will not arrive if they don't?
Oh, you're looking at 5% or something in that order if they paid. Yeah. If they haven't paid, a lot less. I would say probably in the order, before we did that, you were looking at around 20% of people not turning up.
Actually not turning up,
yeah. Something would. It's been a long while since we've been charging now, probably 5 years.
Yeah.
Yeah.
Okay. So they pay £75. What do they get for that 75?
So for that £75, they get David's professional advice in a consultation, and he will obviously look at what their needs and requirements are and look at whether or not he can realistically provide that. So it's professional advice.
Yeah.
We will refer if, for instance, if somebody comes in and they say, I've got hooded eyelids and will Botox work for that, and we go, well, no, look, you probably need to go and see a surgeon. We will probably give a list of 3 surgeons to go to talk about that.
Yeah.
But generally for most people they are suitable, and as long as we've gone through the medical consultation and consent side of things, we will then book them in for a treatment.
Do you take photographs of them?
We do. We photograph everyone. So
everyone who comes in?
Absolutely, yeah. So in general what we will do, that will be part of the overall consultation experience. So they'll come in, and for us we have a Visio skin analysis system. So they will see usually one of our receptionists will go in and take that photograph and just explain what the different parts of that are, because with Visio it looks at other things.
Yeah, so just run through it again. Yeah. So I paid my £75, I arrive at your clinic.
At least half an hour before, come in, you'll be given a cup of tea or coffee if you want it. Yeah. And then we have certain check-in forms as well. Yeah. That we need to kind of look at alongside terms and conditions. So that's quite important from our point of view.
Patients do that themselves, or they do it on an iPad? Or?
They do that themselves. We haven't gone to a digital route yet within our clinic. So we have paper that they kind of sign. They'll be guided through that if they have any questions. Yeah. But in essence as well, because we're Care Quality Commission registered, we need that down as well. Other clinics won't necessarily need to do that. Yeah. They have photograph taken before.
On the Visio?
On the Visio, and then they will have that printed out.
So just to be clear, people may not have heard of the Visio Can you just clarify what it is?
Canfield offer a digital skin analysis system, and this is a brand called the Visia. There are other devices out there that do similar things. I think Canfield is probably one of the top of the range pieces of equipment.
It's American, isn't it?
It's an American system, And in essence, what it does, it takes several photographs that look at a surface image, which is great to have anyway, just looking at what your starting point is. And then it looks at what's beneath the surface of the skin as well. So it looks at pigmentation. It'll look at redness,
sun
vascular,
damage,
sun damage, that kind of stuff.
Quite
as
scary,
well.
actually.
It is quite scary.
Your face in it, isn't it? Yeah.
It is, but so it has two functions.
Yeah.
It gives us a base image that we need to understand. So from a point of view, if we go on and do other further treatments, at least we know what we start with. So if there's any issues from a point of view of them saying you did this and you did that, we know where we stand.
So the Canfield's great because you can analyse, pigmentation, sun damage, blood vessels, and you've got a baseline for those things. It's absolutely great. Now, for people, how much does a Visia cost?
I think it's around £15,000. So.
Was that a good investment for you?
For us, yes, because we utilise this as a selling tool. And so for us, we develop our concept. And as I said, we have our injector who does the injectables, and then we started off with one therapist, and now we have 6 in our clinic.
6 in your clinic,
who do all the rest. Yeah. And the natural additional services that you would build around injectables obviously revolve around improving the skin and complexion.
Yes. Absolutely. So they come in and have the Visia. Now, if people do not have the Visia, there'd still be photographs.
An iPad, a digital camera of some form or another is, I think, important. It's important to photograph anyone before. Maybe not if you're not going to go on and treat them. It's not important. If you are going to go on and treat them, you definitely need a baseline photograph.
And we're going to be talking a little bit to Naomi from Hamilton Fraser, and I think there is a question of whether your insurance is valid if you do not have a photograph.
You've got to have a baseline point.
You've got to have a baseline. A Visia is great, but if you haven't got a Visia, photographs are really important. And it's very important to have very standard photographs, same light, and the same. We can talk a little bit about that.
Really important.
So they have a photo, and then
they go and see David and go through the consultation. And as I said, if they're suitable, then we book them in for another.
Does David talk finances?
Yeah, he will do. Yes, and for us as well. If you're looking at toxin, for instance, the key thing with that is for people to understand how that works. And in general, we're looking here at not just one injection with a toxin, and that'll cure or get rid of your line or wrinkle, as you know. Yeah. In general, what you're really trying to do is to say, really, to get on top of that, depending on how deep that line or wrinkle is, you're going to need at least 3 to possibly 4 injections over the course of 12 months. And that's really what you're selling them. You're not selling them 150, 200, 250 pound single injection session. You're selling them 750 to £1,000 worth of treatment course.
So you find that first meeting, can they have treatment on the first day?
They can if David has time, but in general we do like to be able to give them time to think about it as well. I know it's not mandatory. It certainly is with cosmetic surgery, as you know. Yes. And it does depend on how the consultation goes and whether David has time to do it and whether the patient wants to have it done within that session. But if he's free, and especially if there's been, and that can happen occasionally, a bit of a cancellation or whatever, and he has time, he may offer it.
So how long would that appointment be?
Well, the actual treatment, as you know, takes a few minutes.
But his first appointment
is... His first appointment is always half an hour. Some people offer longer than that, but because David, I think, is very skilled at consulting, very experienced in terms of being able to have, I would say, a proper in-depth discussion and consultation with someone and get across the points that he wants. In general, we found that half an hour is enough.
Okay. Does he have the picture available, or does he just describe their face, or does he have an image that he can draw on? Or
he would have the Visia picture printed out, so he can basically just go through that with someone. In general, though, as you know, really, when somebody's coming in, especially for if we're looking at toxin. Generally, people know, you're looking at an expression, they come in and they kind of go, so it's fairly easy to kind of look at and go, okay, fine, is that...
Well, I find a lot of people don't really know, so I've got a very Have you got an asymmetrical face, Ron? Look at me.
I think everyone has.
Just relax your face, Ron.
Yes.
Yes. So everyone is asymmetrical. Do people know they're asymmetrical?
Well, probably not, but it was really interesting because, I mean, I've seen, like you have, many presentations over the years and discussions about symmetry and beauty and ratios and all those kind of things. And it was really interesting. I went to a presentation recently who said, and someone said, we're not aiming at symmetry. If you aim at symmetry and perfection, people will not look right.
No, that's right.
And so that's quite interesting. So really what you're trying to do is to work with an individual's face and trying to enhance and improve that in a way that they don't necessarily understand, but that a skilled injector will do.
But it's a communication thing. So for instance, Brad Pitt is very asymmetrical.
Yeah.
So being asymmetrical isn't necessarily...
Absolutely not.
...unattractive.
No.
So you really sort of work with explain to the patient what's available.
Yes, correct.
I thought that point a little bit about toxins, about explaining that it's 3 to 4 times a year is important.
It's critical.
How long do you recommend between toxin injections?
In general, it will depend on the toxin utilised sometimes, and also the individual in front of you. Probably now we've gone from 4 to 3 for the majority of people.
4 to 3 months.
Yeah, well, from 4 injection sessions in a year to 3. So
right,
you're right, from 3 months to 4 months.
Yeah.
And generally, I think that's because from an economic perspective and the price points that we charge, and because of David's skill set around hitting the right muscles and and also utilising the right doses as well, as you know.
Can you talk a little bit about the doses?
Well, the important thing is being able to obviously put enough in so you're getting a good result from a longevity perspective, but not too much in that you either cause issues from a point of view of spread and ptosis, or in terms of affecting other muscle groups and having a frozen face, for instance.
So you're saying too little a dose will work, but won't work for as long?
Precisely.
Yeah.
And so this is why when you're looking at people who are offering toxin for £80, and for us, if we know that for an individual, especially for a male, you're going to be using £60 worth of product,
toxin,
it doesn't make any sense, does it? But
so
if you use £20 worth of product, but then if people are coming back every 6 weeks, so you know that to me is one aspect and one element of the market that some people, you know, that the consumer doesn't know and understand, but that from an individual's perspective they say, oh, if it's only £80, then it's cheaper than going somewhere else where it's 200.
Yeah. Okay. So just to say that again, so every 4 months, do you wait for the 4 months? Would you expect some activity to come back?
It depends on the individual, and from our perspective, really what we try and do is to look at selling a package, of course, and most sophisticated businesses do. And if you look at skin, for instance, they will have on their website, if you buy 3 lots of injections over the course of the year, we'll take 10% off.
Oh, right.
So that's a straightforward discount. And what we try and do is to add in value by adding in, for us, because we have therapists, we'll add in hydrofacial treatments.
So we could talk.
It's a different strategy.
I mean, there's great. I mean, hydrofacial is great. Now we've actually, Ron, got loads of questions.
Fantastic.
Which is really, really great. So I'm just going to run through a few of these. So first of all, so Keely asks, how do I find clients when I first start?
Okay. That's a very good question, and that's normally the one that people kind of start off with. How do I get busy? The first and most obvious route, and I'm sure this is something you discussed with them as well, is the first thing you've got to do is to be comfortable with injections and with the results that you're attaining. And the only way you can generally do that is probably through friends and family. And so that then you become comfortable with the fact of consulting, of actually delivering the injections. And seeing what results you achieve.
So it's a bit chicken and egg when you start, because you're not that confident, but you've got to market yourself as confident. Everyone started somewhere.
Correct.
So everyone's gone through that. You know, I'm scared. I don't know what to do. Lie awake at night, worrying.
Yes.
You know, everyone goes through that, don't they?
Well, there are different layers of confidence, as you know. There are some people that can go on a course and I've got it. you know, and I'm perfectly happy to go out and sell my skill set to other people. Now, whether they have or not is another matter, because that's the other end. So sometimes some people can be too confident, and there are people the other end that, you know, until they've treated 10 or 15 people somewhere, really don't feel confident in their own ability.
Yes.
And so it is
two ends of the spectrum there.
It's very individual, but ultimately you've got to feel confident before you start to go out and ask people for money.
Yeah. So it's an individual thing. So I suppose in cosmetic courses, we've some people are confident early. Yeah. And so Fiona Durbin, who's one of our practitioners, is a really great practitioner. She's ex-partner GP. She's one of our lead trainers. She came to a lot of courses before she was confident, and then she likes to tick every box and make absolutely sure.
Well, I would as well, and the problem is now it's the delivery of toxins and fillers is far more complicated than it was 25 years ago, because the indications, whether they're approved or not, have increased, and the expectations from a consumer point of view have as well, in terms of looking at what they're asking for and what they understand can be potentially achieved with toxins and fillers nowadays. So, you know, a standard thing I'm sure you wouldn't be looking at initially would be tear troughs, for instance, when you're looking at an introductory filler, of course, but some people may come in and that's what they want. So ultimately you have to look and go, well, and, you know, personally I would, if I was looking at that, I would be going, I'd probably be referring to someone else rather than trying to look at delivering something I wasn't really trained on or comfortable in, because
I think that's a really important point. What you don't want to do is something you're not comfortable in and have a bad result, because that can really set you back. So always, you know, feel confident to, you know, not to do a treatment. Don't feel bad about that. Okay, Zoe asks, can't wait to start my first course with you. When I complete, do you find your own clients? So we will give you advice, Zoe, on finding your clients. We do have a website which can help you, but please talk to our staff about that. Haley asks, right, this is a good one for you, Ron. Best options for non-prescribers.
Right, okay, so these are people that are nurses but not prescribers. Well, I mean, again, there are plenty of nurses out there who don't have prescribing status. That doesn't stop them from doing toxins and fillers, as you know. But obviously what you have to do is to find someone who is prepared to prescribe on your behalf. You probably have advice around that and a network of people that you could put them in touch with. There's obviously a commercial element to that as well, that you have to build into your business model, because they will obviously want some money. So that makes it less profitable as a business model to operate, but there are plenty of nurses out there that have started off doing that. And then eventually then when they become confident in it and build up a client base themselves, more often than not they go on and actually get the qualification.
I mean, I suppose we would normally, if you are serious in the industry, it probably is best to, you know, we would recommend that you do become a nurse prescriber. If
you can do before, it's probably the best route, because eventually then you have control over your destiny rather than somebody else who you need to go to actually see someone before you can inject them.
Okay. Someone here, I'd like to train in sclerotherapy but concerned about complications. Am I right to avoid such treatments? Can you just tell people, just clarify what sclerotherapy is?
Sclerotherapy has been around for a long while, and sclerotherapy is basically using a sclerosing substance, like fibrovane or sclerovane, that you directly inject into a vein to close it down. And there are different levels of veins, as you know, and I'm sure you're familiar with that as well, ranging from varicose veins, which I wouldn't probably recommend people get into without some form of real understanding around, you know, that's probably the resolve more of a vascular surgeon. But if you're looking at spider veins or thread veins, then there are sclerotherapy courses out there that are available to
I think we have one,
people.
Rod.
Oh, you do? Well, there you go. That's perfect. So yeah, I mean, that's the best thing really, is to go on a sclerotherapy course. As I understand it, you know, it's like any of these things. It's looking at selecting the right people, contraindications, managing that. There are always potential side effects with any treatment, but they are manageable with good training.
Is that something you offer, sclerotherapy?
Oddly enough, it was something that our doctor did, because again, it's a needle-based thing, but he found it actually a little bit fiddly to do, and
you've got to have good eyes, haven't you, Rob?
You've got to have really good eyes, yes.
Yeah.
And in the end, because we evolved and morphed into the laser components of the marketplace now, we have a laser that will do that, and that's operated by a therapist.
Yeah.
So we find that commercially to be better and more viable for us, and then David's just concentrated and focused on the injectable side of things, which actually is commercially better for us. He gets a more return on investment, and he enjoys doing that more, to tell you the truth, than he does do sclerotherapy. Yeah. But it's absolutely viable as a business model. There are lots of people out there with thread veins.
Yeah, it's very common, isn't it?
It's very common, and is an easy thing to add into a private aesthetic business model.
I suppose the thing is, everyone's different. So some people feel more, comfortable doing veins. Some people, everyone's so different, aren't they?
Absolutely.
Some people are more skin. So all practitioners have things they like. Some of our trainers, love thread lifts and the more invasive stuff. Some love the fillers. So everyone's different, I think, is the key message.
Well, they are, and I think ultimately, and our doctor's been through this as well, and actually has tried to do different things that have kind of come through over the years. So I remember years ago, and you're probably familiar with this as well, Smart Lipo.
Yes, that's right.
Which was a laser-based device where you went through a small incision and actually used the laser to try and break up fat cells. So the idea was it wasn't liposuction per se, but that it had a similar effect to liposuction. And what we found out in the end that it really didn't. So it was one of those things where we kind of, and we learned from that as well, jumped onto a bandwagon and looked at claims that weren't really as substantial as we hoped and thought they would be. But also he actually, after the training, felt uncomfortable. He felt his sphere of competence and comfortableness, because obviously surgical training wasn't his background.
No.
So when you start to get into tumescent anaesthesia and inserting people into someone's abdomen, and so, but other people who came from a GP background were comfortable and felt they could take that forward. So
just to be clear there is a type of liposuction called vaser liposuction, where an ultrasound probe is used basically to disrupt the fat. Okay, so an ultrasound probe is put inside, liquefies the fat, and then the fat is sucked out in the traditional liposuction type way. And a lot of people with GP backgrounds are vaser surgeons. So they're not plastic surgeons, got no real surgical training, but they are very successful vaser surgeons. So this is an area you possibly could go into.
It is for our doctor. He felt that it was something he was uncomfortable with eventually, and because of that, we ditched the procedure. We got rid of the machine, and so again that had financial implications for us as a business.
Yes.
But ultimately, at the end of the day, he really didn't want to continue something that he felt uncomfortable with, and again, this is just a learning point. Yeah. And just because somebody else can do it and is comfortable with it doesn't mean to say that everyone will be. And that's the same with injectable treatments. And oddly enough with David as well, he doesn't like thread lifts. No. For him, he doesn't feel comfortable with that. It's one step too far for him. Yeah. But he is a very experienced person especially with fillers as well. And so he can achieve more than probably some people can with fillers.
Yes.
So, it's levels of training, what you're comfortable with. But if you're not comfortable with it, generally speaking, you're not probably going to get the best results. Yeah. And you may have more risks. And at the end of the day, the first thing with this is as well, first do no harm.
Yes. Yeah.
Mitigate risks, and that comes around training. It comes around experience and developing that, and around being really honest with your ability and how comfortable you are at getting good results safely.
Yeah, I would 100% agree with that. If you're not comfortable doing something, there's no shame in that at all.
Not at all.
Everyone's different. Everyone's, some people may be great at fillers.
Yeah.
Somebody may be great at thread lifts. Everyone's got a different skill set. So don't do anything that you're not absolutely happy with. And the really important thing is do whatever is best for your patients.
Correct. Absolutely.
And I mean, in our experience, the most successful practitioners are the people that tend to put their patients first, but have a good business background.
Yeah, I mean, the absolute core tenet, and for us as our business as well, is revolves around the patient or client, whichever you want to call them. And ultimately for therapists working in the business, they will probably call them more clients, and for medics working in the business, they'll probably call them patients. It's just because of their backgrounds.
Yes.
But ultimately the key thing is respecting the individual in front of you, looking at your expertise and tools that you have, and being really honest with whether or not you have the ability to be able to give the client and that patient what they want and what they need. And if you can't, then ethically, really, you should be looking at referring them to other people who can. And so we will as well. And if somebody comes in, as the example I given before, and they come in and they said, I've got lots of loose skin here, will you be able to do something with the tools that you've got? And although we have fractional lasers as well, and that have an ability to be able to tighten skin, they only will do to a certain degree, as you know. And for some of those, it's probably more honest to be able to say, well, you could give us £1,000 and we'll give you 3 courses of this, but you know. But if they're going, well, really, I'm really unhappy with that, you're probably better off saying, well, save your money and go and see a good
blepharoplasty,
absolute good surgeon, and you know.
So you don't want unhappy patients.
Not at all.
You want happy patients. You want treatments that work. That's what we focus on.
Absolutely core, and so what you have to do, and you know, I've had this conversation with our doctor as well around. He desperately wanted at one point when we were getting into lasers, a vascular laser for particular indications. And when we looked at it and looked long and hard and said, well, how many of those patients are we likely to see over the course of a year?
Veins and
It was more for things like port wine stains and those kind of things. And when he was honest, because we didn't really market for that, but they just creep in. You know, we worked out that it may be 3 or 4 patients a month, which if you're going to invest £60,000 in a piece of equipment, is not commercially viable.
So you weren't keen on that idea?
No. So I said, and it's the same as well, people who come with bad acne scarring, okay? We can do some things with mild acne scarring with what we've got, but if somebody's got bad acne scarring, they need probably a full CO2 fractional treatment. We don't do that, and we're perfectly happy to refer to skin. They have dermatologists and the equipment and the experience and get through a lot of those patients to be able to get a good result for them. Now, skin would be our natural competitor for other things that we do, but what we would generally do is go to them, but come back and we'll help look after your skin when they've done that treatment.
Okay, so getting back to, I've come in to see your doctor. He's seen me for that time, analysed, you know, what treatments I should have. What happens then when, you know, when will they come back and have treatments? What sort of program will they put on? So
for us, if we're looking at injectables, generally what we will do, we will look at what we call a package. And so for us with toxins, what we're trying to do is to say, okay, let's say for instance, if it's just this one line here, and normally it's £235, we'll multiply that by 3, take just a small amount off, not 10%, okay? Because if you take 10% off...
What, sorry, so it's £230 for that?
For one area.
2 areas?
2 areas is 325, and then 3 areas is 425.
And
if we're doing like patismal bands or whatever, it will vary depending on how many bands that we need to do. So
how do you judge? How do you judge? You know, I know in America they charge per unit, don't they?
Yeah.
What sort of number are they charging per unit in America?
Oh, well, again, that makes it a little bit more complicated because it depends on what toxin they're using. So if they're using Dysport, for instance, or Azulor, obviously you're putting in more units generally than Xeomin, so it becomes confusing. So you can see anywhere, and I was in America recently, anywhere from $5 to $10 a unit.
Is that for the
well, that's the problem. You don't know what they're using. So someone could look cheaper, but you're utilising more units. So you only know when you get in there, I guess, as to what the quote is going to be. And
so I suppose, I mean, do you want to talk a little bit about the different units between the 3 major manufacturers?
Well, not really. I would say that's probably more your area, but I guess I could look at it from my experience with Botox and looking at initially anywhere between 1 to 3 to 1 to 5. With Botox versus Xeomin, or with Xeomin and Botox versus Dysport. But I honestly don't really know where that has kind of settled, and whether it's still that kind of ratio
I mean, we could talk about that more in the courses, and we're doing clinical sessions, with our trainers. So we'll be talking a lot about the different toxins in those sessions.
And we use all of them, and they're all very good. There's no issue with that. It's just understanding that there are differences in terms of the units and knowing which product you're using and how many units you need to put in to get a good result safely in the area you're injecting.
So I'm going to have 3 toxin treatments in the year. Are you going to book them up? When do you give me the dates?
Our ideal is to basically say, you're going to buy into this course, okay? And so what we'll do, we'll normally say, give us if it's say just one area here, we'll normally say, give us £235 now, okay?
Well, how do people pay normally?
So if we do that, it would be through, well, normally nowadays people don't use cheques, so it will either be cash or more commonly a credit or debit card.
What sort of percentage?
Oh, probably 90% now.
It is.
There are some people that still like cash, but as you know now, I mean, my kids don't, and they never have any cash on them. We're heading towards a cashless society, I think. So generally it's a card. And nowadays, you know, you can take payments through your mobile phone nowadays with an interface, so that's easy and straightforward to do. But from our point of view, what we then try and do is to set up a direct debit for the remainder. So we'll even that out over the course of a year.
So this is something Ron's done, which is quite unusual in your clinic, Medizen, isn't it? So just for me, so I come in, I'm going to have 3 area Botox 3 times. So let's say it's January now, so I'm going to come back in. When will I come back?
Oh, well, then you come back 4 months later.
So that would be February,
what we would
March,
do actually,
May.
you'll come back 2 weeks later for a checkup.
Do I have to come back?
You don't, but generally we would recommend that you do. And in principle, really, for that, after that first injection, you're never quite sure, as you know, exactly what the result's going to be. Everyone's different. And so it's always nice to kind of look and go, where I injected and the amount I used, was that adequate to get the result? And also, have I caused an issue and a problem?
So it's really for your doctor learning about the patient's face.
Well, all of this is, if you think about this, this is a process of what I will call onboarding a client that hopefully you're going to have for 5, 10, 15, 20 years. So you need to invest in that component as part of the process. I know some clinics don't, and some clinics will just go, I'll take that money for that intervention, and that's it, and we'll try and book you in or remind you 3 or 4 months' time to come in and have your next treatment, or you phone us up when it's worn off. Because
before we started, you were talking about repeated treatments and one-off treatments.
Yes. So, well, the beauty of toxin as a business model is it's repeat. Okay, and we've had people that have been with us for 15 years. So if you think about that from a revenue and profit perspective, it's huge. And not only that, they've also gone on and had fillers, and gone on and had skin treatments.
And they've told other people about you.
And told other people about us. So it's incredibly powerful as a business model. But a lot of people look at this as a commodity type of business, and they kind of look and go, okay, fine, because it's competitive, and it is, and they go, okay, fine, so what I've got to do is to offer this at the cheapest possible point, and this is a commodity business, and try and grab people when they're kind of coming in and try and persuade them to come in, and you know, but in essence, this is trying to look at a lifelong process with the client.
Do you think people want cheap if it's your face?
Well, personally, this comes down to, I think, understanding what is achievable through this, and what people are buying into. And there are some people that literally can't afford our prices. Okay, so there are some people that really want what toxin will achieve, but cannot afford, let's say, for instance, £750 a year. Just as simple as that. They will gravitate towards the other end of the marketplace, but they're not our clients. But in general, I think what people want to do is to have a good result and have that maintained safely. But you can't do that for £100 commercially.
No, it's very difficult. And so we would always advise. So just before we move on to questions a little bit, so talk to me about non-medical people doing fillers and toxins.
Well, I just, like you, I don't agree with it, but at the moment there's nothing really there that's stopping it. And as you know, there are self-regulatory bodies there in the JCCP and Safe Face that have their own sort of, I guess, view on this. Ultimately, I think that if a non-medical person can use one prescription medicine for one indication, well, why do we bother with medics? Why can't they just use anything? And unfortunately, there are non-medical people also using liraglutide, which is it's a prescription medicine for diabetes in the NHS, and they're injecting people for weight loss, which I think is...
So how do they get hold of it?
there's always routes of getting hold of product,
yeah.
as we know.
And it's potentially extremely dangerous.
I agree entirely.
So I've heard of people injecting lower eye bags with non-medical trained people with, like glutathione, and it's potentially blindness, very, very dangerous procedures. So it's not illegal for people to...
Unfortunately not.
No. So essentially in the UK, we're one of the least regulated countries for toxins and fillers.
We are.
We are involved, as you are, with the JCCP and governments trying to increase the regulation, and we hope that will happen in the future.
I hope so.
Yeah, we really hope so. Okay, let's move on to a few questions. So Rachel has asked, to have a successful business, do you think you need to offer fillers as well as Botox?
I would say no, not necessarily, because they are two different indications. But obviously, you restrict the number of clients potentially that you're going to be able to treat. So clearly, really, with toxins, probably the majority of people really are coming in for this line here, and then secondly, it's crow's feet, and then thirdly, really forehead lines. So although, as you know, you can do lower parts of the face, generally that's not what people understand what toxins do. So you can make a business model around it. You can,
but really...
It depends. I mean, if you look at it like this and kind of think, if I had just have 10 or 15 people coming every month, and they're going to give me, I don't know, say 150, 200 pounds for that, you can make a business out of it.
Yes,
for sure.
So some people do that.
They do.
So I think the key is that you don't need very many patients.
No.
So a GP may have 5,000, 6,000 patients on their list.
Yeah.
But because of the recurring business model, you know, how many patients would you need, regular patients, to have a...
Well, this all comes down to, and again, there's a broader question around this. This comes down to, what do I need from my business? And that comes down to another question, which is, how much money do I need every year?
Yes.
And how am I going to earn that? So you can earn that from your GP practice.
So sort of work backwards, really.
You've got to work back, but what do I need the money for? Also, how much, I always say to people when they kind of say, what are the two key, what are the most important numbers in my business?
Yes.
Business professionals may look up
ask me,
and loss.
What do you think they are?
What are the most important numbers in your business, Adrian?
Well, they say turnover is vanity, don't they?
Yeah.
And profit is sanity.
Yes.
And cash is reality.
Yeah.
Is that right?
That's true, but I would go way back from that, and I would
you?
go, okay, personally to me, and I run 3 separate businesses. I've got a distribution business, consulting room, and Medizen, but every year I look back and go, how much money do I need to fund my lifestyle? And how many days...
Looking from the look of your suit, it's quite a lot, Rob.
It's not that expensive. No. And how many days holiday do I want to take? Those are the 2 most important numbers for me.
Just run through those again.
Okay. So how much money do I need to support my lifestyle? Okay.
Yeah.
So that's, my expenses, my mortgage, car, all those other things, kids, and all those kind of things.
Do you aim to save money?
Yeah, of course. Well, because that's the other thing as well. You've got to look at, and I'm getting older. At some point, I'm going to need to save for when I don't work. Yeah. And the other part is, how many days holiday do I want to take?
How many days do you want to take?
Generally, I take 30 to 35 days a year.
So
and that's outside of your bank holidays.
Yes.
Yeah.
Yeah. Okay. And you've got a business partner, haven't you? You've worked with a long time with. And does he have the same ethos as you?
Yeah. Absolutely, yeah. And so if you work back from that, then you then have to look and go, right, how can I structure my business to support that?
Yeah. I suppose I would agree with you. So basically, I was an NHS consultant, and a lot of my friends are still NHS consultants, or my wife is a GP. And I think from what we hear from the delegates, basically this gives you freedom. So the way Ron is talking is, how much do I need to earn? How much holiday do I want? What do I want my lifestyle to be?
Yeah. And
you can do that.
Yeah, absolutely. It's the only way to do it, to work backwards, because otherwise you don't really know what you're trying to build.
But if you're working for someone else,
correct,
can you do that?
Of course you can. I started working for someone else. I worked for a pharmaceutical company.
Yeah.
So I was an employee. I had a salary, but I had to go into work every day to get that money.
Do you prefer being your own boss?
Oh my God, yes.
Yeah.
I'm sure you do as well.
Yeah. So I suppose the thing is, this industry is great because you can be your own boss and you're in charge of your own destiny.
Absolutely.
So I've got a lot of friends who have been made redundant, had things happen in their lifetime, and very unsure, what's going on with them.
Yeah.
But in this industry, you're in charge of your destiny.
Well, you can have, and for a lot of people, they kind of think it's scary to leave an income stream that's kind of guaranteed, and within the NHS it is. Okay. Yeah. But obviously you have restrictions in terms of the time, the holiday that you can have, and that all depends on the partnerships that you've got and what you're doing. But and for most people, actually, because it's the NHS, okay, it is pretty much guaranteed. If you're working in the commercial part of the market, in the pharmaceutical industry, I could have been fired at any point in time. That's the risk that you got.
Were you fired at the end?
No. Luckily I left, but I could have been. And then, what have you got? Nothing. You've got to then find your next job. I can screw up my business, okay, but nobody can fire me.
No, absolutely.
So that for me, I find empowering.
So that suits you.
Much better, yeah.
Talk to me a little bit about your subscription. You encourage patients.
Yes.
Your package. You've got different packages.
We have.
You?
Yeah.
Can you talk a little bit about those?
Yeah, sure. So in essence, really, what you're trying to do is to break down the costs for an individual. So if you go to someone, for instance, and say, okay, it's toxin for a year is £1,000. Let's just make it easy. And you have to give me all that money up front for the package. You'll have one conversation. And in fact, what Skin do is let's say toxin's £1,000, but if you sign up for a course, I'll give you 10% off. And then what they do it on a credit basis. So they'll say, let's apply for £900 worth of credit.
What? Just run through it. They get credit. How do the people get credit?
Well, they have to go through a credit check.
Right.
And then basically the money then comes from somebody who's going to provide the credit, a credit provider.
Right.
And there are different companies out there like Braemar Finance. You may be familiar with this for bigger procedures like breast implants or whatever. People sometimes seek credit for that because they can't afford it all themselves.
So what sort of percentage of people are credit based or?
Well, for us, we don't like that because A, it's a lower amount, and B, you have to put people through a credit check. Yeah. And C, you lose 7% of that generally because the credit provider needs to make their money. So if you offer it as interest-free credit, you're not going to get all the money.
Okay.
So for us, providing a direct debit facility, which is basically asking them for their sort code and account number, and basically saying, if you pay upfront £200 and odd, that'll pay for the first injection, and then you've already prepaid before they come in for the second one.
Does your doctor talk about this, or does someone else in the team talk about
Our doctor will introduce it as a concept, and then if they're interested in that, the reception staff or an administrator will run through the mechanics of it and set it up for them.
So I'll pay you £220 initially, and then my options are credit, which isn't your preferred option, or a direct debit.
Direct debit.
So how much will come out of what are the options?
And it depends on whether it's 1, 2 or 3 areas, but generally it might be anywhere between, say, £40 to £90 or something like that a month.
Okay. So what if I need fillers and other things?
That's slightly different, okay. And with fillers, what we can do is pull together what we would call a bespoke package that's based around their individual needs.
Yeah.
And then phase that. But the aim always is to try and ensure that we've got prepayment for it rather than providing them with credit. Yeah. So it's basically like saying, put your money into piggy bank, but instead of your piggy bank in your home, put it into our piggy bank. And then when you come in, we know you're paid in advance, and then we'll deliver the treatment, and then you put your money into a piggy bank again. And what we then do, instead of slashing prices for that, we'll add in hydrofacials. And the core component around that is that if they're worried about this or the shape of their face, they probably also want nice looking skin.
Yes. So
we deliver nice looking skin with a therapist.
And how many hydrofacial machines do you have running in your clinic now?
3.
3, and they're running all the time?
All the time.
Okay. So we could talk a little about hydrofacial treatments, which are absolutely great. So in your clinic, you have one doctor delivering the toxins and fillers.
A doctor, a nurse who's also supporting, and in fact another doctor now who's come in. So we've got 3 people who are delivering injectables.
And and how many estheticians?
We've got 6 estheticians.
Full time?
Yep. So some of those, they'll all deliver hydrofacials, but we also have lasers. We've got mirror dry, which is...
What, mirror dry?
Mirror dry is a cure for auxiliary hyperhidrosis.
Yeah.
And fat freezing with Zeltique. So we've got 2 fat freezing machines.
They work well?
We've only just bought into that actually around 5 months ago. So I would say that we're still learning with that business model. Yeah.
Okay.
They work, but it's not easy to bring those clients in.
Next thing, your turnover.
Yeah.
What increase? What percentage are you looking for increase?
So generally year on year, we're trying to look at around about a 25% increase in turnover. Yeah. That's our aim and our target.
Do you make it?
Some years we do and some years we don't.
What was last year?
Last year we turned over just around 990,000.
990,000.
Yeah.
In your clinic.
That was in the clinic business. We have a separate business model. No, we have a separate business model which is basically revolves around clinical trials.
Right.
And so at the moment we're currently running 4 clinical trials, and that's something that could be brought into an aesthetic business model and can be quite lucrative.
Is that separate from that first number you told
me?
It
is, yes.
So just be clear, Ron, so you have your clinic medicine increasing 20-25% a year.
Yeah.
You have the trials business.
Clinical trials business, yes.
Separate business?
Yeah.
Okay. Then you've got your distribution business.
That's a totally separate business, yes.
Selling
selling hydrofacial, basically. So yeah, we have 320 clinics now that have hydrofacials around the country, and we have Salesforce that goes out and does that.
So it's selling the machines and supporting them.
Correct, yeah.
Okay, and hydrofacial machine comes from?
From the US. It's based in California.
Yeah. Do you get trips out there?
Yeah, I was out there earlier in the year. Actually, we're in Los Angeles, so it's quite nice this time of year.
I can imagine. And the machine hydrofacials are really big.
It is. It's. In fact, it was quite interesting. It's the second piece of aesthetic equipment to hit over $100 million turnover in history. First one was Zeltique, which is, as you know, cryolipolysis, fat freezing. So it's quite interesting. So
100 million
in turnover in a year. So yeah, and they predict that business is going to be $1 billion turnover business. So which is interesting.
And just really quickly for the viewers, what is it?
So hydrofacial basically replaces microdermabrasion and superficial chemical peels and LED systems.
Yeah.
And in essence, I guess in short,
you can throw all those machines away, can you?
Basically, yeah. And it improves the health of the skin. It's a skin health treatment.
How does it work?
So basically, the concepts are, if you want to look at it from a medical perspective, is mechanical exfoliation, stimulation via superficial peels. So that's glycolic and AHA. You've got extraction component to it, infusion of low molecular antioxidants and hyaluronic acid, and LED, which is a collagen stimulator.
Has it got all of those?
All of those, all in a box.
So basically, to summarise it, it's a machine that shoots stuff at the skin.
Yes, kind of, yes. It exfoliates, but it gets glycolic acid down to the epidermal dermal junction, which is where you want it. Yeah. So if you look at glycolic acid, it's actually a stimulatory molecule. Yes. So you're stimulating. So
it stimulates the deeper layers and removes the superficial layers.
Yeah, and there's an extraction component which is pretty unique. So it basically sucks out all of the in-ground makeup and dirt and pushes out blackheads.
You see it, can't you?
It's a canister at the back, and which is a bit of a wow factor for people. Yeah. So you clean the skin and then you infuse in hyaluronic acid and antioxidants, so clean substances.
And there's a light element to it as well.
And LED as well, yeah.
So it's a great treatment and is really becoming very popular, isn't it?
The reason we like it is because it's repeat.
Yeah.
So we have people come in every month.
Yeah.
That's perfect.
Yeah.
The price point's around £125 a treatment.
Yeah.
You've got therapists delivering it. They build a bond and a relationship with people in a way that you don't do with a 15-minute repeat intervention with injectables, and that's the problem.
Because they're spending time talking to
So that you build strength in depth with other people in your business, and that's how the beauty industry works. Actually, it's around relationships and around instant gratification. So at the end of the treatment, people look in the mirror and they should go, wow.
You've had it?
Oh yeah, yeah.
Is it a wow?
It is, yeah, absolutely, genuinely it's a wow.
What looks different when you...
Your skin looks healthy, hydrated and clean. And at the end of the day, after injectable treatments, there's not necessarily a wow. And that's it. Generally with medical treatments, there's not the wow at the end of it. There will be hopefully at some point, but it's not that instant gratification. The beauty industry revolves around wow.
Yeah.
Somebody goes in, their nails don't look nice. After 40 minutes or whatever, they go, wow. You know, they go in, they look pale, spray tan, wow.
Yeah.
Hopefully.
And this goes well. Right. So we've got loads of questions. Okay, I'm doing really well with questions. So Alex said, how can I find a prescriber?
You will probably know more about that than I do, but people do and have used the site that we've got called Cosmetic Recruitment, where you can advertise on there for a prescriber.
Okay, and please contact us if you'd like information about how to find a prescriber. Contact Cosmetic Courses and we'll be able to advise you on that. Okay, I'm scared to advertise. Are before and after photos allowed?
They are, as long as they're, I mean, ideally they should be your own.
But so that's important.
It is important, but you know, companies will provide you with images, before and after images, but obviously it's not your own work, and ideally you want to promote your own work, because then you can show people what you can achieve in your own hands.
So what I see with people using before and afters is the light is bad before and a flash used afterwards. Yeah. So, you know, use the same lighting because people will look much less, look better with a flash.
Yes.
Yeah. So you are allowed to use photos. What other restrictions are there on advertising, Ron?
Well, around fillers, none really, as you know, because they're not prescribable, even though you and I probably agree that they probably should be, especially because they contain lignocaine, most of them, which is a prescribable substance. But that's
a whole other topic.
Topic. Obviously, because Botox is a prescription medicine, or any brand of toxin is prescription medicine, you can't advertise that directly to the general public.
So you can't advertise the word Botox?
No.
Or Azular, or Xeomin?
No.
Okay, so I was in Manchester the other day, and I saw a clinic with Botox injections
all over
here.
And at the end of the day, somebody will probably report you. It'll be a competitor, and the MHRA actually really governs the advertising of prescription medicines, and advertising standards and CAP guidelines. All of those things kind of meld together around what you can and can't do, and what you can and can't claim. Yeah. And the key thing is that I'm sure you probably cover this as well in your courses, is to understand what you can and can say about, from a marketing perspective, injectable treatments. Yeah. But it's important that you do that, although you will find people that will advertise it. Yeah. In essence, it's illegal, and so I wouldn't recommend it. It's not a long-term route. And you can't advertise it through pay-per-click. So if you try and go to Google, for instance, and look at pay-per-click advertising, they won't allow you to do it.
Can you explain to people what pay-per-click is?
Yeah, sure. I mean, anyone now probably going onto their mobile phone, if they're searching for instance, a provider of a service.
Yeah, like holidays or insurance or whatever.
Absolutely. Yeah. Pretty much now, the first 3 or 4 results that you'll see on your phone will be adverts.
Is it obvious they're adverts?
Has a little ad next to it. It says ad, but it's not always obvious.
But in the old days, they used to be a yellow, or they used to have the ones on the side. So nowadays, it's much less obvious.
It is less obvious, but in general, for pretty much any search term now, it's going to be someone who's going to be advertising. Yeah.
And this is how Google makes its money.
It is indeed, and we use pay-per-click as well in our clinic for certain things. Not for injectables, but we do it for mirror dry and for cryolipolysis.
So basically, with pay-per-click, and it's very easy to do, isn't it?
It's probably not as easy as it was.
But it's easy to set up.
It's easy to set up, absolutely, yeah.
But it's the sort of thing that's easy to set up, but it's easy to do badly.
It is. And in general now, although we ran our own pay-per-click campaigns years ago, it's become so sophisticated now that we outsource that to another supplier. And in general, you find that the costs of employing that specialist are outweighed with what your spend is, or your click-through rates for the actual advertising budget.
So just a little tip. So let's say Ron is in Birmingham, and he wants Botox Birmingham. Anyone who searches the word Botox Birmingham, he wants his Medizen to appear first on Google. Now you can do that every time someone puts those words in. It's going to cost Ron.
Except you can't use Botox, of course, because it's prescription. Okay. But if you want to look at, for instance, tear trough treatment Birmingham, or lip, let's say lip filler. Lip filler would be one. That's a big part of the market. There's lots of younger women especially who want lip fillers. So if you put in lip filler Birmingham and then you have a little advert underneath, which, it might kind of go, I produce beautiful lips, I'm expert, whatever you want to kind of put in there as well. When people click through onto that and it goes through to your website or what they call a landing page, that will cost you some money.
Roughly how much?
It varies enormously. It varies on the area, how competitive it is. In London, it'll be more expensive for sure. It'll be less expensive in Aberdeen.
Yes.
But it can be anywhere between 50p and probably £5 or £6.
So just for one click.
Yeah.
So it really is quite sophisticated. You can actually draw exactly which area you want your ad to appear. On a map, you can map out where you want it to appear. You can set daily limits. You can say negative words, which you don't want.
Yes.
So bad Botox, Birmingham, you don't want to... No. So I suppose what Ron's saying is if you are considering pay-per-click, be very, very careful. Set a budget. And if you're going to be serious, perhaps get a specialist to help you.
I would say so, yes, definitely.
Okay. Yeah. How else can people get patients? What other sort of Instagram, websites, Snapchat, Facebook?
Yeah, there are lots, and I would say certainly social media now, especially for I would say the younger people coming into the marketplace who are younger surgeons, and you'll see this as well.
Yeah, in surgery,
You'll see in surgery some of the younger surgeons that are coming are utilising these in a way that the older surgeons still never would, and a lot of that is because they are unfamiliar with social media, don't use it themselves, are uncomfortable with it, or maybe even think it's not ethical as well. There's lots of misnomers around it, but actually for certain target audiences, there's no doubt that social media is very, very important. Yeah. And
I read an article recently that social media is now more important than published papers.
Oh yeah, I'm sure.
In patients' perspective.
Yeah.
So it really has changed. We're in the middle of a revolution.
We are, and everyone now lives their life on their phone, and that is the way to if people are spending most of their time on some social media platform, if you're not on there trying to talk to them in some way, shape or form, but other people are, your competitors, you may be at a slight disadvantage.
Give me a quick rundown. So let's do Snapchat, Facebook, Instagram. Is there another one? And websites, let's say.
Well, YouTube, and obviously you've used YouTube a lot, and that's another social media platform. In general, I would have said probably years ago, Facebook would have been the key one. Yeah. But now, especially if you're looking at a younger audience, so for instance, my girls who are in their 20s, Instagram's, Facebook's for older people now.
Yeah, it is. Instagram, Snapchat.
Snapchat they don't use, and I think Snapchat's probably less so. It's one of those, and it's much harder to manage. But Instagram, and again, you can do live videos on Instagram, and you can put all sorts of images on there, and again, if you can gain engagement on that with potential customers and have existing customers, even more importantly, try and talk to potential clients and patients, that can work well as a strategy. Yeah. It's not easy to build. But it is one of those things that it's generally time and effort put into it will result in interaction, which hopefully will result in clients coming in your door.
So Instagram is a personal thing. It needs to be done probably every day, and you build up slowly. Right, a few questions. Now, someone has asked, Ron, there's a few questions about VAT here.
Yes, okay.
So I'm afraid you've got to answer that thorny question.
Yeah. This has been something in the industry that's been there for a while. And in general, I would say that the rule around this is whether this is a medical treatment or not. Yeah. So for us, for instance, and we've treated people with migraine with Botox for many years. Yes. Now, clearly that's for a medical indication, and you wouldn't be charging people VAT on top of that. Yeah. The aesthetic side of things, for frown lines and wrinkles, really comes down to a medical judgment around the needs of that. And in general, it probably revolves around psychological needs and assessments rather than a cosmetic, because we're looking here at a cosmetic result. I'm not an expert in this, so I don't deem to be. Yeah. But if you're going to be generating or are generating currently a turnover of more than £85,000 a year, I think it is. Yeah. that's the point where you need to consider VAT registration. I would recommend that probably you get in touch with someone who's an expert in that area in our industry, and I would recommend someone called Victoria Donnelly, who's an ex-HMRC inspector, who's an accountant that provides specific advice. In general, if you go to your own accountant, they will probably just say, get VAT registered.
Yeah, I think, so basically it is a bit of so essentially some conditions are not VAT registered. So I think clothing, so children's clothing, is children's clothing?
Yes, that's right, yeah.
Yeah, food is not VATable in the UK,
yeah.
Am I correct on that?
Correct.
And medical treatment, so if you have your varicose veins treated, that wouldn't be non-VATable because you've got a medical problem. The question really is, is non-surgical treatments, medical treatments, and you really need to talk to a specialist about that, a VAT specialist, as you say, because we're not sort of tax experts. So I would advise you, and always be on, err on the side of caution with all these things. Okay.
Okay.
So Ron, so really interesting. I mean, so the industry is changing rapidly.
It is.
What's your prediction? I know there's new toxins coming out, aren't there?
There are actually, and we're doing some trial work on one actually, which is quite interesting. I can't tell you what one it is, but there are new toxins that are coming out, and there's two aspects to that. Number one, as you'll know, in the Far East there are several toxins that are available in the Far East that aren't available here.
Can you tell us a little bit about those?
From a point of view of looking at the dynamics of them, as far as I understand it, really what you're looking at is something that's going to be providing a rough equivalence to the duration of the current toxins that are available. Again, depending on the number of units that are injected, obviously. There is a toxin in the States that's been investigated through Revance that's actually claiming a longer duration of action.
So Revance, just to be clear, Revance is
It's an American company.
Yeah.
They were originally looking at a topical toxin,
right?
Which they were looking at for axillary hyperhidrosis and also for crow's feet. Yeah. And they basically ditched that.
That didn't work.
Didn't work.
Essentially because as I understand it, the molecule doesn't penetrate the skin.
Well, that was always the understanding generally, but they felt they'd been able to work a way of being able to get enough of the product into the skin, which actually for one reason or other didn't really work. But they also have in their stable a longer acting toxin. Yeah. And they published some results recently in Jean Carruthers, who I'm sure you'll know as well, has been involved in that, and she was, she's one of the most
doyens.
She's doyen, of the injectable marketplace. And it looks as though this toxin is lasting between 5 to 6 months.
Right.
So there's a potential advantage there. Obviously, people only coming in maybe twice a year instead of 3 to 4 times. But the substantiation of those results is key. So they're performing further studies. Yeah. And obviously the price point will be key as well. Yeah. One would imagine it's going to be more expensive. I would say in the States, possibly you might be looking at next year.
Yeah. So 2020.
Yeah, I would be looking probably a year or two after that. So I would say if there's going to be any new toxins, it's likely to be along the lines of a Far Eastern toxin. Yeah.
Tell me about those, the Far Eastern toxins.
Well, in general, as far as I understand it, the way they compete in the marketplace is generally through price points. Yeah. So they're lower priced than your established toxins that you have at the moment. And a lot of them have very big market shares in those parts of the world.
So what countries?
Korea, and I think in China as well. Yeah.
So and they're licensed there?
They're licensed there.
So when are they likely to will they become licensed here, do you think?
Well, that's what currently the industry is looking at. If you look at Merz, Galderma and Allergan, who are the three that are involved in the UK, they certainly feel that a competitor could be coming out in the foreseeable future. Now, when you're looking at drug registration, as you probably know, there's no guarantee around when a drug will get licensed, and from a submission point of view, and whether or not the licensing authorities will ask for more data or whatever. But I would probably say, maybe this or next year is feasible. Yeah. Yeah.
Okay, so someone mentioned a short-acting toxin.
Well, there has been one for a while, and that's botulinum toxin type B, as you'll probably be aware. And we've utilised that a few times in our clinic where people have had, and it's very rare, as you'll know, but they have developed possibly some form of antibody to the type A's, and it's not worked. Yeah. and we tried a type B, which is more expensive, but generally shorter acting, and found to have some. So
people not reacting to type A, but that's interesting.
But it's very rare that we use it.
Yeah.
And generally, there's no advantage. Obviously, there's a disadvantage as to having a shorter acting toxin.
Okay.
Yeah.
So before we finish, I'm going to pop some quick questions in you, Ron. So fillers.
Yes.
What fillers do you use? Why?
Yeah, we've used Juvederm for a number of years, and principally I think it's in essence because our doctor has worked closely with Allergan. Yeah. We've done a lot of clinical trials. He was involved actually in a published study on Valbella before that was launched. Yeah. And I think it's just the relationship and the fact that he's very comfortable with utilising that product. They're a
premium product, really?
It's a premium product. There is some support and branding from it, from an Allergan perspective as well, and so that doesn't hurt if a company is putting money into making that visible direct to consumer, and they've invested money in that. But there are lots and lots of other very, very good hyaluronic acid based filler brands out there, and we also still use occasionally Sculptra.
Really?
Yeah, which is a kind of a blast from the past. Yeah. But again, there are some. It's not.
Tell people about Sculptra. So Sculptra was big.
It was
a few years ago.
Yeah.
So there's like a lot of things. There's a place for it.
Yeah.
And what is its place?
So its place really is for people that, and there are what we would call gym bunnies, people that are just naturally thin and exercise a lot.
Burn their fat off quickly.
Yeah, and they seem to burn through hyaluronic acid really quickly. Yeah. And so they don't get a very good longevity. And so for those people you can use, which is polylactic acid, as you know, and basically it's a collagen stimulator. Yeah. And as you know, you need a series of usually probably 3 injections in an area, and you will get an end result over a 6-month period. So it's a different mechanism, but is a nice treatment and works well.
And what's well for HIV? You know,
associated lipodystrophy, and that was the original work that was done.
Well, was it Newfield back in?
Newfield, it was. It was called Newfield.
Right. Yeah, a long time ago.
It was. So, but again, if you're going to utilise that, you need to be trained.
Yeah, absolutely.
I don't know whether you run courses on it or not.
We don't. Maybe
not,
we should.
And I think it has a place without a doubt.
Yeah.
So, yeah.
Brilliant.
Okay.
So I think that's probably, time up. We'll do this again, Ron.
Yeah, lovely.
It's been an absolute pleasure.
Thank you for inviting me. Yes, thank you.
Talk to you again, and no doubt we'll see you again, because we could talk all day, couldn't we?
Oh, we could, yeah. Okay.
And last little thing, if anyone out there doesn't see the Consulting Room's newsletter, could you mention? Yeah,
I mean, the Consulting Room, well, we have an industry magazine now as well, so if anyone wants to subscribe to that, that's quarterly. If they email me, ron@consultingroom.com, I will make sure that you get that, and that's a free publication.
And an update on the industry and what's going on.
Okay.
Ron,
thank you, Adrian.
Thank you very much.
Thank you.
Take care.
Cheers.
Discala. How do I pronounce that name?
Discala.
Discala. Where does that come from?
Italy.
Sounds very Italian.
Yes.
Who is the Aesthetic Insurance Manager of Hamilton Fraser. Now, some people think insurance is boring.
No, it's not.
It's not boring. And it's really, really, obviously, really important that you are properly insured and if there is a claim, you are covered just for your safety and peace of mind. So tell me a little bit about your background.
Okay, so I've been with Hamilton Fraser for 10 years now.
Yeah. What did you do before?
I worked in a coffee machine servicing company.
Did you?
Yes, when I was finishing university.
Yeah.
So I started there in another part of the business, in the tenancy deposit protection scheme that we have there.
Yeah.
I moved into the insurance division after about 2.5 years and ran the claims department for 5 years.
In the coffee business?
No, in Hamilton Fraser.
Hamilton Fraser, yeah.
So I did all the claims for the medical malpractice.
Yeah.
So I saw it from that side first.
Yeah.
And then 3 years ago, I moved into the role I'm in now. So I look after claims and the sales teams, but also getting out and about, seeing people.
Yeah. Just tell us, so for how many years did you work in claims?
5 years.
5 years.
Yes.
And what claims were they? Were they non-surgical claims or were
Mixture. So I still look after some of that team. And the highest claims that we see are non-surgical because naturally those are the ones that we are insuring more of.
Yeah.
So you would expect to see a higher rate.
Now, we don't want to scare you guys, but it's, I think it would be interesting to sort of understand the sort of claims that are coming and whether they're becoming more or less. Mm-hmm. So what sort of claims are you seeing?
Okay, so the top 3 claims that we see are for dermal fillers, so non-permanent dermal fillers, and for Botox and for laser.
Okay, so shall we run through these?
Yeah,
so
they are decreasing slightly. I did do a comparison from 2008 and 2017. Although the volume reported is only the difference of about 4 or 5, the actual percentage for the dermal fillers and Botox and laser has.
So you're saying there's the same amount of claims, but many more people having the treatment?
Yeah.
So is it getting safer?
I think so. I mean, compared to when I first started doing claims, so nearly 8 years ago, it's gone down. So
should people's premiums be going down then?
They are.
Are they?
Yes.
That's good. That's good news. Yes, so we could talk a little bit about that. Yeah. So why do you think the claims have gone down?
I think techniques have got safer, training has got better, and I think there's more experience in the market now. So that when there is a complication, people are able to turn to more experienced practitioners and get the help a lot quicker.
Yeah.
And before, the products that were on the market hadn't been out for that long, so some of them caused more permanent damage, for example, and a lot of the damages now aren't permanent and they're resolvable, or it can be claims about just dissatisfaction and things like that, but people know how to deal with that better.
So you're saying the products are better, the techniques are better,
training's better,
treatment
better, and the experience of the practitioners.
Okay, so talk me through. Can you talk me through what's the worst claim, if you're allowed to say?
So it was some years ago, but we have had blindness cases due to a filler sculpture.
Yes.
So we've had more than one blindness case over the years.
From the same treatment?
From a similar filler, but it wasn't sculpture on the second one.
Any lessons people can learn, do you think, from that case?
Well, a lot of the lessons that are learned in all cases, to be honest, and the reason why we have to settle many claims is not actually because there's been something done wrong. It might be that the side effect or what's occurred for the patient is actually expected, but it's things like the consenting and the paperwork and the record keeping, that's what lets the claims down. And then there's a risk in the litigation and we have to settle. Yeah.
So what's really interesting, and it's the same for plastic surgery, is it's often not what you've done or what's happened, it's the consenting process which is causing you the problem and your paperwork.
Yes.
Would you agree with that?
Definitely.
So run me through what you think people should be doing consent-wise and what they should be documenting.
I think it's really important from the outset to build that rapport with the patient, first of all, and that's so you can get them to be more honest with you, so you can manage their expectations and really...
So spend time talking to them.
Yeah, just understanding their motivations behind wanting to have that treatment. understanding what they expect to get and whether you can actually achieve that. But documenting those kind of conversations as well and having them noted on the paperwork.
So in the first consultation, when you first see them, what sort of things should people be writing?
Well, it sounds basic, but we have had cases where we've had no paperwork at all. So we need the name, address, the medical history, where possible, if you can get a psychological medical history as well.
So what should you ask for psychological medical?
Well, I would refer back to the manufacturer's consent forms. I'm not medically qualified, but the idea being if they have a body image issue. So
how would you know?
If they have got, for example, and they feel that they've got a defect on their face, for example, that's actually not obvious for anybody else to see, but it's something that really bothers them.
Yes.
Or there's something much deeper in terms of their body image and how they're unhappy with the way they look. That would be sort of an indicator.
So if you're saying if you sense there's an issue, what would you advise people to do? How?
Just understand whether or not you're going to be able to meet that expectation of the patient.
And if you don't feel you can?
And if you don't feel you can, then it would probably be worth not treating the patient and to turn them away.
And have you had claims people have got body dysmorphic problems who've...
It's been compounded by a treatment, yes. I mean, it wasn't necessarily obvious initially to the practitioner, but it has come out when medical expert reports have been done for the claim.
Okay. So in plastic surgery, I think it's similar. We have forms which I fill out for every patient, which is a medical history, has to be filled out. As a man, if I'm seeing a patient, the chaperone has to sign. We always have to have a chaperone. It has to be documented. Who is the chaperone? The patient has to agree to a chaperone. Do people need chaperones with?
No, not necessarily.
Not necessarily.
The only cases I've come across when GMC has put a requirement for that to be on somebody's registration, which is because of something historical that might have happened.
If someone's seeing someone, not faced, do they need a chaperone?
No, it's not a mandatory requirement.
Okay. So for plastic surgery, it really is, but obviously not for. Okay. So what do they need to document? Medical history?
Medical history, psychological history, the motivation of the patient and what expectation you've told them you can achieve.
So whether taking allergies, that sort of thing.
So there's going to be any contraindications with the treatment that they're having.
And when they write what the patient would like, the aspirations, what sort of things should people be asking and documenting, Naomi?
Understanding what they want to achieve. So if they're saying that they want to come out looking like Kim Kardashian, for example, and it's completely unrealistic, that should be noted. And the reason why I say that is because a lot of the time when we get solicitors' letters with allegations, there's a set type of allegations that they'll send through, and the patient will allege that they weren't told that they weren't going to achieve that particular.
Just say that again. So the letters you get from the solicitors, what would be an average one?
So it will start with their expectations weren't managed, so they didn't think that the treatment was going to come out the way it did. And although you might have done the consent process, if you haven't sort of documented those conversations within the notes, it's very difficult to evidence that you did have that.
Give me an example. So someone may feel they're going to look
30 years younger, but you're not going to be able to achieve that. So you advise them that you're going to be able to do X and they will look like this. Then to make sure that they've understood that and taken that in, sort of they are happy to proceed on that basis, should be put on the consent.
So Naomi, what's the most robust thing? So when you see the patient's notes, sometimes your heart sinks.
Yes.
Sometimes,
you know that it's going to be a struggle.
You know you've got a difficult one on your hand. What are the best? What makes you happy to see?
Lots and lots of information, and I know everybody's busy, and I know it's very difficult to write everything down and keep all the admin up to date, but it's so important. So the more information.
So what? Just tell me a few tips.
So for example, aftercare. So everybody will say what the aftercare is, for example, but I would always recommend either giving a physical copy of it to them or emailing them a copy and getting them to tick or to initial on the consent form to say they've received it.
So just to run through, so I had an issue years ago. I performed facelift and eye surgery on a patient. I always gave an information leaflet. There was a separate one for eye surgery, a separate one for face surgery. I ticked information leaflet given, tick. And she had watery eyes in the wind when she played golf. And it was on the eye one that they could get, that was a problem, the potential issue. Wasn't on the facelift one, and I couldn't show from my notes which one I'd given.
Okay.
And that was an issue.
Yeah.
All I had to put was eyelid information leaflet given, and it would not have been a problem.
And it sounds very, very picky, but the solicitors will pull it apart, and it is a risk, and it's very difficult to then defend. So it's important to be very specific. So, if, for example,
do you advise a checklist?
It depends on what type of consent form you use already, and a lot of people will be using manufacturers' ones, which are very robust in terms of the amount of side effects that are listed. But if you're developing your own paperwork, then checklist is ideal. But be very specific. So if, for example, you're using performing a treatment in a different area, and the side effects are different, then we'd recommend to have a separate consent form for the two areas, because the side effects will be different, so the consent process isn't the same.
So a different one for toxins, different one for fillers?
Yes. And if they're coming in for the combined treatments all in one session, they should all be completed.
So if some patient's having dermal fillers and toxins, both?
Two separate,
Okay, so run us through what would you like in the form? In the document, what ideal documentation would be?
It would be all of the side effects, and that they've been warned of them. That, as we said, the medical history, the expectations and their motivation behind the treatment, the aftercare has been given to them post-treatment. If you can have, some people use diagrams, for example, of where they're going to place the filler, for example. That's always useful. Notes after the treatment's been done, that it was how it went, if it was okay, if the patient was well. With injectable treatments, we require photographs to be taken before and after for every single treatment.
So tell me, what sort of photos, what's the best place to store them?
It depends on how you practice. A lot of people are now digital, so they're using their iPads for the consenting. All of those softwares are absolutely fine. That's not a problem. And actually, most of them make it mandatory for photographs to be taken during the consent. If you're doing paper, then it needs to be stored with the patient notes and lockable cupboard or what's it called, filing cabinet. So it doesn't matter really, as long as they're secure, as you would with the patient notes. But every single appointment, really, we would recommend it. And I wouldn't just say injectables, although the policy condition is just says injectables. I would say for every single treatment you're doing, because that's your evidence. With the digital world that we live in now, with telephones all being able to take selfies and modify them, it's very easy for a patient to go away, distort a picture and say that that's what happened to them when they left the premises.
Have you had cases of that?
Yep.
What have they done?
They've sort of modified a picture of themselves, made themselves, you can darken images, can't you, and all that, and put different contrast on there, and then they've submitted it saying that was a side effect of the treatment.
Well, they made themselves look terrible.
Or bruised or something like that, and then tried to make a claim. But if a practitioner has evidence of how they left the clinic, and if they saw them for a follow-up appointment, what they looked like at that stage.
Do you take a photo before and after treatment?
Yes, and I know that with, say, for example, injectables, it might not be an immediate result that you see. It's not so much about the result sometimes, it's more about how they're physically leaving and what they look like at that stage. And it's just proof, it's more the evidence for you.
Okay, so a photo before you treated them every time and a photo afterwards.
Yes.
Are you covered? Let's say you can't find the photograph.
Yes. Are
you still covered?
We would still handle a claim for the injectables. It would make it very difficult to defend, and it would be likely that it would go to a settlement. It would be down to the insurer's discretion, though, ultimately.
So you say if the insurer is within their rights to say...
They are within their rights. No insurer wants to decline a claim, especially for this type of policy.
Why don't they want to decline a claim?
Because you want to look after the practitioner, and if there is an injury to a patient, you want to look after the patient as well. And it's about people. It's not about, for example, in property insurance, it's not about a house. For example, as much as you want to rectify the house and get it back up and running, these are people, and it's a livelihood for a practitioner, their reputation, their practice, so it's dealing with things in the most efficient way that's in the best interest of everybody. So insurers don't like to decline the claim, but if, for example, there was repeated examples where there were no photographs and it was an injectable claim, then it would be within their rights to decline it.
Okay.
For other treatments, however, if there were no photographs, they wouldn't decline it because it's not a policy condition. It's a recommendation that photos are taken.
It's a policy, so for aesthetic treatments, and it's interesting, so afterwards, as they leave the clinic, they need a photograph. And I mean, it's just a silly thing. So we had problems years ago that we had photos, but it wasn't documented the date and the time.
It's very useful to have that information on there.
So if they're taking a photo on camera,
yes,
you have to set the date.
Yeah, you can do. Or if, for example, some people will upload them onto a computer and print. I've seen them on just an A4 page where they've printed them out afterwards, but they've documented on that underneath them what the date and time was. Yeah. We will always come back if we haven't got dates and times to ask the timeline of the photographs, because if a solicitor's looking at it, they might not have an idea of the timeline, so they will ask for more information. So if it's done from the outset, that saves a lot of work at the end in the event of a claim.
Okay, so documentation, photos, really important. Anything people can do to reduce the risk other than that?
Make sure that you are responsible if you receive a complaint, and I would say don't get defensive. If you receive a generic complaint that somebody's not happy with the treatment, deal with it professionally. Don't take it personally. See the patient if you need to, review it, obviously document all.
Have you seen problems where people haven't done that, maybe?
Where people are non-contactable in the event that the patient's got a problem, it exasperates the situation, and we find that they will then go to their GP or an A&E department, for example, if they feel they've got something medically wrong, and they're not necessarily aesthetics isn't necessarily understood in the same way in those environments, so it's handled slightly differently to how an aesthetic practitioner would deal with it. So if you're not contactable, it would be advisable to have a peer or somebody that you might have trained with or something like that you can put as a contact, just so there's a follow-up process for that patient. Because if they lose faith at that stage, that they can't come back to you or get advice that they need, then chances are they're not going to come back at all. And I've seen cases where that's happened and they've just gone then straight to a solicitor.
Okay.
But you might be able to prevent that.
Okay, so basically if you look after your patients, even if they get a problem, they're less likely.
And the ones that are looked after properly will still have 9 times out of 10 they've come back for more treatments later on. If they're allowed to have more treatments and it's the right thing to do.
Maybe different treatment.
But they've maintained that patient relationship and not lost them, and that's what's important.
Yeah, so I think that is really important. Although it's difficult, your natural tendency is maybe to hide away. You mustn't do that, and you must engage if you do have an issue. And there's always help, so if you do have a problem, we're happy to see them here at Cosmetic Courses, or you can ask for a second opinion, can't you? And that's, So any other tips, people?
Make sure it's signed, the consent form, and dated. Sounds really basic, but it's really difficult if it's not. And there are times where we will see unsigned consent forms for the patient and the practitioner, and dated at every appointment. So if there's follow-up appointments, important to make sure that those are dated correctly.
So just to be absolutely clear, every treatment you do must have a treatment-specific consent?
Yes, it needs to be treatment-specific.
So if they have toxins, they have to sign a toxin consent?
Yep, that's correct.
If it's fillers, if it's sclero.
Yes.
Yeah?
It has to be, because all of the side effects are different for all of the treatments.
Are there any treatments you don't need consent for? So laser?
Need a consent form, and you need to make sure you're doing your patch test.
Okay. What about some of the skin treatments?
Everything needs a consent form.
Hydrofacial?
Consent form. I'm going to say the same.
So you say everything you do?
Absolutely everything. Because they all have different effects, and they all do different things. So it's important that it's documented specifically to those treatments.
Okay, that's really valuable. I'm not sure if people are consenting.
Most of the time I'm seeing that they are. The majority of the time they do. There have been cases where it hasn't been done exactly the way we'd expect.
Do you have to, just a quick question, do you have to have the name on every page? So our consent is sort of 4 pages.
Yeah.
And the name's obviously on the front.
Yeah.
And I've noticed at the top it has, names, but often it's not filled out.
I haven't seen that be an issue before.
Yeah.
I mean, providing that document is kept together, then I can't see an issue with that.
Okay. So anything else people can?
Be prepared, I think, for complaints. When we're saying don't shy away, just have a procedure in place in your mind or documented down that you will follow. There's no set right or wrong way of doing it, so to speak, but it takes the panic out of it. I find a lot of sort of individual practitioners that are out there working on their own mobile, for example. It's quite scary and daunting when they get a complaint. When they get their complaint.
How do complaints normally come in? So in my experience, not that I've get, they're either a patient comes in unhappy,
yes,
or very occasionally you get a solicitor's letter out of the blue. Okay, how long have they got after treatment to put their claim in?
3 years and 4 months.
From what?
From the last date you've seen them. If there are extenuating circumstances, they can apply to the courts for a longer period of time and do it outside of that time frame. But I've only seen that once.
So just explain that again. So 3 years and 4 months
from the last appointment.
From the last time you have set eyes on them. Yeah.
Yes.
Okay. So it's not within that time.
No.
Okay.
But if, for example, a side effect hasn't come out until 6 years down the line, they could apply to the court and say it wasn't present within the time frame that is required. Can I make a claim?
Okay, so you've got, okay, so there's that approach. So if a patient comes back and says, look, let's say they have a reaction to the filler.
Yes.
Yeah, and an abscess or something, yeah, big swelling. Okay, they come back, you treat them, it gets better. Should you let the insurance company know you've had a problem?
You should let us know. And it wouldn't be set up as a claim or anything like that. We'll just note the details.
So what cases should I let you know about? It's not a formal complaint.
It's not a formal complaint, but you should let us know if you receive a solicitor's letter.
Yeah.
If you get a request for compensation directly from the patient.
So if a patient says, can I have my money back?
That's not a request for compensation, that's a refund request. If they ask for anything above that, for being out of pocket for saying travelling to you to come back for the follow-up appointments, or they ask for a set amount as compensation, because some patients will do that directly.
Because I've had a treatment, I pay you £300, I say, Naomi, I'm not happy with it, can you give me my money back?
Yeah, and because I haven't been able to go to work, because I wasn't able to go out for 3 days, I'd like you to reimburse the lost salary, for example.
You let the insurance company know then?
Yeah.
If I just say the £300?
You don't have to, although we have a very good team that can actually help you write the letters and responses to patients in order to give a refund. So although it's not a mandatory requirement, it's worth you doing because you might get some advice that you don't have.
So you're saying every case. So what happens if I feel I've made a mistake and someone's had a problem, I've resolved it, or they may be unhappy? They haven't made a complaint, but...
No, but you can talk to us, and we won't, as I say, we won't set up those scenarios as formal claims, so there'll be no impact on the policy at all.
So people are worried.
Yeah.
You know, if I go to you, I'm very busy, every time someone's got an issue, I come to you, I'm going to be telling you all the time I've got potential issues. I'm worried my amount I've got to pay you, my premium's going to go up.
As I say, because they're not formal claims until you receive the solicitor's letter, request for compensation, those are the only ones that we would formally set up. We would just note the situation on the policy, so it wouldn't impact on the premium at all, because we're just giving advice.
So I can talk to you as much as possible.
We're here to be supportive. We're not here to take your money, as most people think insurance firms are.
You're nice insurers.
Yeah, we are. But we try and use the experience of all the claims that we've got and had and dealt with over the last 20 odd years to give you the best advice, so that if you have got a situation that isn't quite a formal claim, we can help you prevent it from getting to that stage where possible. It's not always going to be the way, but we will do our best, and that's the aim of it, not to put premiums up.
So we do. So someone's unhappy with the treatment, you think they may go legal route. Can you give them the money back? Can you and ask them to sign a waiver?
If they have suggested they are going to go down the legal route, I would recommend speaking to us first of all about how you do it. On our template letters, we have got a disclaimer on the bottom of the letter once a refund has been given as a gesture of goodwill.
And what does this disclaimer say?
It says it's in full and final settlement of this matter, and they have to sign it to say they accept it.
Is that legally binding?
No.
Naomi?
No. But it does act as a very good deterrent.
So let's say someone's had a treatment, you both agree it hasn't worked, or you know there's been a problem with it. They say, you know, can you reimburse me yourself? You know, might want to go and get it fixed elsewhere or whatever. You don't feel you can. Do you advise people to, perhaps bite the bullet, give them their money back, rather than to avoid illegal?
Not necessarily. If what we would do is ask your opinion first of all, what you feel.
My opinion.
Yeah, as the practitioner.
Yeah.
And we would go through the situation, whether all the documentation has been done. If we feel there's any risks at any stage, then we may suggest it. But at that point, until it's a formal claim, it's up to you ultimately.
Yeah.
And if you feel that actually a refund isn't necessary or shouldn't be given, then we'll support you in that.
Yeah.
If we feel it's going to massively antagonise the situation, depending on the circumstances, then it might be wise to, but we will listen to you.
Yeah.
But we have got, again, templates to offer further treatment if it's appropriate, as a gesture of goodwill, and to actually maintain that you've done nothing wrong and you can't provide a refund.
So I know a lot of plastic surgeons, a lot of my colleagues would just sort of say, well, because of all the hassle and heartache of going the legal route, they do just basically
provide the refund.
Yeah. So particularly as there's an excess on a lot of policies.
With plastic surgery, the excesses are always going to be a lot higher than the non-surgical.
What sort
treatments.
of numbers are the excesses for plastic surgery?
It can vary, but anywhere from probably 5,000. I've seen excesses of approximately £50,000, but that was on a policy where there had been lots of claims.
So if a plastic surgeon has a lot of problems, you will insure them, but the excess will be...
The excess will reflect and the premium will reflect. Plastic surgery, the claims are much higher.
What's the biggest claim?
£500,000.
That's the biggest one, isn't it?
Yes.
Okay. What's the biggest one for non-surgical?
350,000.
Yeah, so still quite big though, isn't it?
It was, but that was because there was problems with the documentation, if I'm honest, and that caused it to go on for a lot longer, and the legal costs on that particular one were massively more than what the patient got, and that's what we often find.
So it's 500,000. Is that the total?
That was the total,
including legal fees.
Yes.
So the lawyers.
It wasn't actually. It wasn't a terrible amount if you look at it like that, because that was everything.
How much would the patient have got?
I think in that scenario it was £120,000.
And that's the biggest amount of patients in the UK?
On the surgical side. Not in the UK, just that we've experienced.
And a non-surgical?
No, a non-surgical was 350,000.
But that went to the... But some of that went to the lawyers?
Yes, a lot of it goes to the lawyers.
We
find that the patient's lawyer cost is usually about 3 times the damages amount, if not more.
Oh, really? So on that £350,000 claim, the patient would have got...
They got about £100,000 because there were injuries on that particular one.
And the lawyer would have got...
The rest of the money.
The rest of the money.
But we also, you've got to bear in mind there's defence costs as well, so from our side.
Oh, right.
But our defence costs are much, much, much lower. So because of the volume of claims that we deal with and the volume of clients that we have and the size of the business, we have much better rates. So they're much, much less.
Do patients pay tax on the money they get?
They pay a fee, usually. It's usually a percentage out of it, or the solicitors will take that from them.
But is there,
No, not like when you get paid.
It's not like, no. Okay.
No.
Okay. All right. So claims are going down.
Yes.
We're all going to take our photos and
please.
Is there anything else we can do? I mean, communicate with you?
Always communicate with us. We're always here to help. As I say, we're not a house insurer. Well, we do house insurance, but we're not a home insurance team. We're here to talk to you and advise, and where we can give any advice that might help. Yeah.
Question I'm often asked. So you do your treatments. Mm-hmm. So you do insurance for a couple of years. Yes. So you do non-surgical treatments for a couple of years. You're insured. You give up. Yep. Okay. Mm-hmm. If your existing patients have got 3 years in which to start a claim. Yes. Okay. Are you still insured 2 years later? So it depends on how you stop. So if you cease trading, retire, go on maternity leave or emigrate, the policy will offer something called an extended reporting period. You have to see the policy to the end of the policy period at that time. You can't cancel it mid-term to qualify. But if you see it to the end... So you mean you've got to go for the year? Yeah, you need to see it for the full year. At that point, we would then offer 5 years of extended reporting for any claims to be responded to. So we would cover you for those. Do I have to pay for that? No, it's free of charge. So I pay for my year. Yep. I give up halfway through as long as I paid for my year. Yep. At the end date of that policy period, we'll lapse the policy and you will get the 5 years. I've got 5 years. And it's very unlikely I'll get sued after 5 years. Very unlikely. We've not seen it. Okay.
in that scenario.
Good. Right. Okay. So someone setting up in, just started, just done a foundation course, thinking about it as a career. When should they contact you? What are they likely to pay?
Okay. So we would always need people to be fully trained first of all and have completed the training courses of the treatments that they wish.
So you can't get insured until when? Until
you've had the training.
Yep.
So once the training is complete, you can obtain a quote from us at any time. At that point, we can put it.
What would you be asking for? What information?
So we ask for if you're registered with the NMC, GDC, or GMC, what treatments it is that you're going to perform, the turnover that you're anticipating you're going to take in for the year, and we would always suggest underestimating that slightly.
What happens if you say it's a number and you exceed it, but you haven't told you? You've done really, really well in that year. Yeah.
In the event of a claim, the insurers may look at that.
How would they know?
Well, it would be down to honesty at the end of the day.
Yeah.
But they can ask for copies of accounts.
Can they?
They can do.
Yeah.
And it may affect, they may say then that you need to be charged an additional premium.
Has it ever happened that someone said they're in this band, but they're not, they're in that band?
Yes.
And they have a case. Have the insurers actually looked at their...
I haven't seen it happen, no.
Haven't seen it happen.
And I haven't seen a claim decline because of that either.
No.
But honesty is the best policy.
Yeah, absolutely. Yeah.
But we have minimum bandings of turnover, for example. So if somebody's starting out, our minimum turnover banding would be about £40,000 for the year.
Yeah, so 40,000 is turnover, not profit.
Turnover,
yeah.
Yeah. And that would, say for example, you're doing the toxins and you're doing dermal fillers.
Yep.
So that's all minimum premium pricing. That would be a policy price of £580.
Yeah. Can you pay it in one go?
We can offer a direct debit over 10 months. There's a 7.5% interest charge, so it works out approximately £58 a month for the first 10 months of the policy period, and the last 2 months are then no payments.
Okay.
You can pay by backs, cheque.
So I pay my money and then I'm insured.
You're insured.
And I've got all your support.
Yes.
And everything. And then let's say in the first year I do really well and I turn over £100,000. What happens then?
Then you need to let us know.
Yeah. So when it looks like when I've gone past that number.
Yeah, when you've gone past that number and you've got an idea of what you're expecting to achieve, we can make an adjustment to the policy, increase the turnover. It will affect the premium, and the premium will go up. But it's proportionate. It's not. It depends what treatments you're doing as well to how much it goes up.
Okay. Now you mentioned that toxins and fillers are low tariff naming.
Yeah,
what are the big ones then?
So treatments such as hair transplant, for example, FUE and FUT methods, they're more pricey. Laser treatments it is a higher policy premium because we see high volume of claims, and payments that we pay out for laser claims are higher than what we pay out on a toxin claim.
Yeah.
So it's proportionate to that. So the policy premium for a laser minimum premium policy would be around £1,300.
Really?
Yeah.
So do you insure aestheticians to use lasers?
Yes, subject to the right training and then having an MVQ level 3 in general beauty.
So can an aesthetician come straight to you, or do they have to be part of a clinic?
No, they can do it privately.
Okay.
Yeah.
And if you have a clinic, so we're talking to Ron earlier who's got a clinic, with number of aestheticians, would he, as a group, do the aestheticians have to be individually insured, or can Ron...
It depends on how they're employed. So if they are all employed and being salaried through the clinic...
And don't work anywhere else?
They can still work elsewhere, but if they're salaried through the clinic and all of their work is invoiced in the clinic's name, then they should be on the clinic's policy.
They don't have to be insured themselves?
No, not unless they're doing private work outside of the clinic.
Okay.
If they're doing that, then they're not going to be covered by the clinic's policy, and they need a separate policy for themselves. If they're on a self-employed basis, that they're working for you, then they should have their own policy.
Right.
We would probably note them on the corporate policy as well, just to protect the entity, but it all depends on how it's being invoiced, the work. But if, for example, a patient has got a problem, they're more likely to go back to the clinic as the person that sold the service than the private practitioner.
But if the aesthetician has done the treatment, okay, but there's group insurance for the clinic, can the aesthetician be sued individually?
Not if they're employed by the clinic, no.
They can't.
No.
But if they work externally, they can. If they're like a consultant, they can.
Yeah.
Okay, so they need to get their own insurance. Okay, so if you're a nurse,
yes,
and you work for a clinic, 99% of your time, but you do a few treatments at home with your family and friends,
you need a separate policy.
You need a separate policy. Yeah. Okay. If you're very, very small and you just treat family and friends,
yes,
do you still need a policy?
Yes, I've seen family and friends sue practitioners.
Tell me about that, Naomi.
Well, people fall out.
Yeah.
3 years and 4 months is quite a long time. So within that time, other things can happen within a family, or friends have fallen out for whatever reason.
And sued the...
And then to get their own back, they've said...
Really?
Yeah.
For no... Has there been a problem, or is it...
Not necessarily. They've just tried. And a lot of the solicitors that will deal with the patients will take on a case if they feel there's any risk associated with paperwork, for example. And if they feel that they can make a claim, but they don't really care what they're doing, the solicitors, they will make the claim.
Yeah. So typically what happens to me, you get a letter requesting the notes.
Yeah, there's two types of letters you receive. You get one like that requesting the notes, and that usually is an indication that the solicitor feels that there is a case potentially, but they want to go through the notes just to check if there's anything else that they can try.
So these are the no win, no fee.
Yeah.
So you've fallen, you think you've had a bad treatment, or for whatever reason, you go to one of these solicitors.
You explain the situation to them as what's happened. If it's a clear-cut case that there's been an injury or a side effect, for example, if there has been an injury, you're not likely to get the request for records straight away. You're more likely to get a full letter of claim with allegations. There'll be a request for records within that, but you'll get allegations. If it's something quite minor, and they're not sure whether they're really going to be able to pursue it, they'll request the records. Okay. They'll receive those. If everything's by the book, you probably won't hear again from them because they don't feel that they've got.
So I've had that a number of times. So
your paperwork must be good then.
Well, I've made sure. Yeah, I've really worked on making it good. So then that goes away. No more problems. Yeah.
Yes.
Okay. When do you have to give them the notes by?
There's usually a timescale on the letter that can vary, to be honest, but as soon as possible would be recommended.
Okay. How long should you keep notes for?
10 years.
10 years?
Yes.
So you have to have that 10 years worth of notes?
Our policy condition is 10 years.
Okay. So what do busy people do with notes? You know, have you had issues with people who can't find the notes?
Yes. It doesn't mean they're not going to be insured. Or a claim's not going to be covered, but it means that we're much more likely to have to settle the claim because we've got no evidence. So
you've had a case where someone sued, you've gone to a practitioner, can I see the notes and photographs? Yeah. There is nothing.
Yeah, I've had one recently.
Right. And really, what happens then?
It's pretty indefensible, to be honest, because you've got no evidence of what the treatment was or anything like that. So the solicitors are more likely to say, let's make a settlement of the case. They might do it on a without prejudice basis.
What does that mean?
So it means that there's no admission of liability, that the practitioner's done anything wrong, but because we can't satisfy the rest of the claim, we'll make a payment.
Can you do it with prejudice then?
If there's been something wrong, you can say you can admit liability. But I would not recommend the practitioners to do that. I'd let the solicitors tell you whether or not that's appropriate.
Yeah. Okay, so let's say, I get a request for notes.
Yes.
I send them the notes. Everything.
Yep.
So can you withhold anything?
No.
Does that include whatever has been written about the patient by anyone in the clinic?
Yes. Everything needs to go.
The whole lot needs to go.
If you've got an instant report form, for example, for something that's happened, all of that information. Okay,
so that all goes over to the solicitor. They may or may not.
Might not pursue it.
What happens if they decide they're going to pursue it? What happens then?
Then you'll receive a formal letter of claim. And that will be the one that details allegations of why they're holding you responsible for whatever's happened. And then, when you receive the request for records, you should let your insurers know. But by that stage...
So request for records is, you must tell you straight away.
Yes, must do. Because there's an indication that there might be a claim.
If they don't?
It could prevent the claim from being covered from a late notification perspective.
How late?
As soon as possible. Late? I mean, we would say within 30 days most, but as soon as possible.
As soon as possible. So let you know immediately. Phone you up, talk to you about it?
Yeah, talk to us, emails. I get notifications in all sorts of ways these days. But email, a telephone call, whatever works for you.
And who should they address that to? The claims department?
The claims department,
okay.
yeah.
Okay.
But, I mean, they can come through to my team, and that will then be transferred over. It depends on the situation.
Okay. So it all goes through. What happens then?
We will then also ask for a copy of the records.
Yeah.
We will notify the insurers.
Yeah.
They will then...
So you're not the insurer?
We're a broker. So
Yeah.
we work on behalf of Hiscox, who are our main insurer.
Yeah.
And we work on what's called a delegated authority. So we've got a document of our contract with them, technically, of what we're allowed to write in-house. So we don't have to refer every policy to them. We can do it all from our office, and we can act as the face of the insurer.
Yeah.
So we
They don't have to do much.
Well, it's not so much that, it's we've got the more experience than them. They haven't always been our insurer, and we've got the background. We know the treatment.
How long have they been your insurer?
3 years. Okay. But before that, we had one insurer for 20 years prior to that.
Okay. Yeah.
So we have the authority to write a certain amount of business. If it falls outside of that contract, then we will have to refer it to them.
Okay.
So in the event of a claim, we'd notify them. We don't have authority to deal with formal claims like a solicitor's letter in-house. So we would notify them. They would then decide whether they want to appoint solicitors. And we have a set solicitors that we use, that we have a set rate with, for example, so the costs are lower for everybody. They will then go through whether it's covered under the policy, whether the treatment is listed on the policy, for example.
Do you get treatments? So you get people with a policy and the treatment's not?
Yes, they haven't told us they're doing that treatment, not updated us.
What happens then?
The claim isn't covered by us. We can't cover it because we weren't insuring the
So
treatment.
let's say I do Botox and fillers.
Mm-hmm.
I start doing another treatment.
Yep.
I forget to tell you about it. I have a problem with that.
Mm-hmm.
I go through the whole process. Then I get a letter saying you're not covered for that.
Potentially. Well, we'd speak to you about it.
Yeah. Who's liable for the money?
You'd still have to deal with the claim.
I personally.
Yeah, so you'd have to appoint a solicitor independently.
Right. Okay. So really important that.
It's going to cost you a lot more money.
Yeah. So you need to let you know if you're doing it.
And also, when letting us know what treatments you're doing with dermal fillers, we are brand specific. So we need to know each individual brand of dermal fillers that you're using, because there's so many that vary in strength and length of stay in the body, for example. We rate them differently.
Okay. Do you need to know all the toxins you use?
No, toxins, we do cover them all as standard.
Okay. So, but if you take it, if I do if I could try one new filler, I've got to let you know.
Yeah.
Okay.
It won't cost you anything to add it onto the policy.
No.
But just let us know so we can update it, and we're insuring you for it.
Okay. So make sure that everything you do is listed on the policy. Okay. And then it goes to the solicitors. Then what happens?
They will then look over policy coverage, decide whether it's going to be covered for whatever reason, and then look at the circumstances. So when we ask you for the documentation, we'll also ask you for a summary of events, what your opinion is on what the allegations are. We will then decide whether, with what we have, evidence-wise, whether we can deny liability or not. They will then write a letter back.
Who decides that? So
it'll be the solicitors.
So what happens if the solicitor says, I think we can't deny it, but I say...
We take your argument on board, and we get that quite a lot.
What do you get?
We get people not wanting to go down the assessment route, for example.
What assessment route?
A settlement.
Yeah, right, okay.
So they don't want to settle the claim.
Okay, so you say to me, Adrian, we think we need to settle this because your notes weren't great or whatever.
We'll tell you what the risks we see.
Okay, and then I say, I think I've got a valid argument for not settling it.
Yeah, so we put that back to the solicitors.
Yeah.
If in some scenarios they will say, okay, we will try a denial of liability, but be aware that we might send that out, and quite likely we're going to get back an argument against it, and we're going to continuously go through the claim. Or they might say, well, no, unfortunately, that's not.
So the solicitor may say, I'm sorry, Adrian,
we have no other option. If you still don't agree with that, that's absolutely fine.
Yeah.
But they will then, they can turn around and say, this is the settlement amount we would have paid. We feel that it would be right to settle the claim. We're going to give that to you.
Oh, really?
And
then you sort it out?
Yeah, and we're not going to deal with the claim anymore.
Oh, really?
Yeah. Okay.
So let's say, a classic thing, I've had a problem with a filler, someone's had an abscess, someone's got a problem, we've fallen out, I haven't seen them, I haven't followed them up, they're really unhappy, they go to their solicitor, tell me when I go wrong. Solicitor says, let's get the notes bad, your solicitor reads it and says, Adrian, I think we need to settle this one.
Mm-hmm.
Yeah?
Yep.
What sort of numbers are we talking?
Depends on the treatment. It depends on what the effect is.
How do you decide?
There's something called, there's some guidelines with negligence claims, and depending on the area of body that's been treated, the nature of the injury, whether that's going to be a permanent injury or something that's going to be resolvable.
So permanent injuries are bad?
It can cost more.
Yeah.
It also is proportionate to the age of the patient.
Yeah.
So if they are a young female, for example, and they've got the next 60 years of going through their life with a permanent injury, it's how that's going to impact them over that period of time. But if they're slightly older, then it might not be such a high cost. So there's a set criteria and
so there's
brackets.
There's a payment for the injury.
Yes.
But is there also a potential loss of earnings?
Could be. They could submit that. They can also submit the psychological damage.
Yeah.
Which we get lots more of that these days. And it'll all be proportionate to how it is actually impacting them. So if we've got a psychological claim on top of the physical injury, then we will get medical expert reports. We'll get a psychological report done.
So tell me about the medical expert reports.
Okay, so that's where we would appoint an expert in a particular field of the treatment. We would say to them, can you see this patient and write a report independently of how you feel that injury is impacting them, whether the treatment was performed correctly, if you can, and your views on it.
Okay.
But it's got
and
to be
the
very objective.
prosecution may have an expert witness as well?
Quite often there will be two.
Okay, so then let's say we agree liability.
Yep.
What would the average claim?
So for your Botox and your filler type claims, very low. It can be £1,000.
Okay.
So it's quite low. For laser, because it's more, we see more burns and scarring,
which is more
permanent. And depending on where that is on the body, you could be looking at somewhere between £5,000 to £10,000 potentially, if not more.
Okay, so let's say for a Botox treatment, a patient gets ptosis. Do you get those cases?
Yes.
Are they, because it's a temporary thing, do they?
This is where it comes down to the paperwork being correct. So although it's a side effect that they might have consented to, for example, when they will have been made aware of it, that potentially could happen, it's resolvable as well. If the paperwork is at risk of not being correct or thorough enough, then we potentially could pay a damages payment for that. And it could be on the basis that, for example, they couldn't go to work for the days that it was getting resolved, or they couldn't go out, they missed an event, they come up with all sorts of wonderful reasons why they need the money. But yes, we can.
Are lawyers interested in claims that small?
It's about frequency and volume, I think, with solicitors. So if they've got a high volume of claims that are all that price, eventually they start seeing the costs going up for them. So it's a lot quicker for them as well to pursue a claim like that than, say, a surgical claim. A surgical claim we would find will go on for a lot longer. So it can take a couple of years to resolve.
Okay. And you settle these. So that case, someone's had a ptosis.
There was a risk with the paperwork. We would recommend settling it. We would.
A patient would get
X amount, £1,000, for example.
And the lawyers would get
probably about £5,000 to £6,000.
Oh, really? Yeah.
It's very disproportionate.
Okay. So that would be pretty typical.
Yeah.
Okay. What happens to the practitioner's premiums?
Depends on the payment and how much we've paid out.
How do you judge it? How does it?
It's proportionate to what they're paying at the moment.
Yeah. Would one claim make your payment go up?
Potentially.
Yeah. Two.
Yeah. So how we would do it, we would potentially load the policy, is what we call it. We put an increase on it, but it depends on how much we've paid out.
Yeah.
So if we've paid a minimal amount out, then it might be sort of a 2% or 5%, something like that.
Okay.
If we've made large payments, it could be.
What's a large payment?
I would say anything from £30,000 upwards.
Yeah.
Then we could put 30% on there.
Okay.
But if we're seeing a frequency of claims and all for the same treatments, then we may increase the excess specific to that particular treatment.
And what's the normal excess?
So for Botox and fillers, £0.
Yes.
Absolutely nothing. For laser, £1,500.
Yeah.
For things like hair restoration, it can be £7,500.
Okay, really? Yeah. Is there a lot of litigation in here?
Yes, there can be.
Why?
Because I think it's an expectation of results, actually, and dissatisfaction. We get more notifications opposed to formal claims that go through. There aren't many injuries that we see from that.
No.
But it's
just disappointment.
Yeah, disappointment. And it hasn't worked as well as they thought it was. And it's, I think, quite personal. I mean, everything, all the treatments are, but it's quite a personal self-image issues, hair restoration, I think.
Who's more likely to be litigious, men or women?
Well, I'd say that women are more likely to be having the non-surgical treatments, although we do see men.
Yes.
So the volume is probably higher for women in terms of how many claims we get. But we do have quite a few males that have made claims.
Yeah.
As we see the rise of them in treatments, I think their expectations are quite high.
Yes.
And if they're not met, then they will pursue it.
Yeah. Okay. We've probably got some questions here. Anything you'd particularly like to add? Naomi? Anything you think is important for our practitioners out there in the world?
I think don't be scared to talk to your insurers. I think we're not here to put premiums up. That's not our goal. Our goal is to support and provide advice and education. So talk to us. We're quite human people.
Oh yeah.
And we've got lots of experience to provide you with the advice. So if you've got a situation which you're worrying about, then give us a call.
Okay, a few questions here. So Mandy Malone says, do I have to have additional cover on my policy to be a prescriber for another practitioner?
No, but what you do need to make sure that you do is have the training for that particular treatment. So if you're prescribing for the botulinum toxins, then you need to have been on a practical and theoretical training course. And we would recommend listing it on your policy, but you don't need to list the prescribing element.
Okay. Do I have to have before and after pictures in order for treatment to be supported by insurers?
We would highly recommend it, particularly with injectables, but not for every treatment. It's not a stipulation.
Not for every treatment?
No, but we would recommend having it for every treatment because it's more information, but the policy condition is just for injectables. Okay. But so
for laser it's not?
No, it's not a mandatory requirement, but it's a recommendation.
Okay. Do I need to show certificates? This is Claire. Do I need to show certificates for all treatments I perform?
We do ask for training certificates. Appreciate that we don't always get them all at the outset. If there is a claim, however, we will ask for a copy of the training certificate.
Oh, really?
Yes, so it's probably better just to give them all to us in the first place. We'll just put them on the file and then it's done.
Okay, so if you can't produce them, you may not be covered.
Not that you won't be covered, but we would ask, for example, you to go back to the training course and see if you can get a copy or get a letter to say that you completed that course. We'd find another way of getting evidence of it.
So you might go back to the course provider. Okay. Jodie asks, where should we store patient records, documents and paper consent, considering GDPR? Big one. Is it a locked cabinet suitable, or are electronic records more suitable?
There's no stipulation that one is better than the other. So electronic records are fine as long as they are in the sort of a cloud-based area. I'm not technologically minded.
What happens if you want to switch with one cloud base, and you want to switch to another one? Yeah. Can you get your records moved?
I believe so, but I don't know enough about clouds and technology, if I'm honest.
What happens if the company goes bust?
Then you're going to have to move the records if you can, but if you can't get copies of them, and that's the reason you're not going to be penalised from an insurer's point of view.
So let's say,
but it's going to be difficult.
So I can't keep records myself. So can practitioners keep photos on their phone and locally?
We wouldn't recommend it, no.
Because?
If somebody gets access to that phone, and it could be a family member, then it's a breach of GDPR. Because you don't have the consent of the patient to let your mum see the photos of the patient.
Is there litigation regarding that sort of thing?
We don't see that because we don't deal with the GDPR side of things, but they could be potentially.
Okay.
But in terms of lockable filing cabinet, that's absolutely fine. We'd suggest sort of a 2-lock rule. So if it's in a locked cupboard, it should be in a locked room as well. So you need to get through 2 locks to get to it.
Okay. Have you had people stealing?
No, but we've had floods, for example, that have ruined records and we're not able to reproduce. But those are extenuating circumstances taken into consideration by insurers. Yes. It's outside of control. We've had patients take notes away.
Oh, really?
And
steal them?
Yeah, so if they've been on a training course as a model, for example, and they know how the system works, we've had a couple where their notes have suddenly disappeared. So when the practitioners come to receive this claim, they can't find anything.
Oh really? Mm. Okay. Have you had any claims where practitioners have written things they shouldn't have written in notes?
I've seen them modified after the date of the treatment or when we've asked for notes.
So now that is really interesting.
It's difficult to prove, but there have been some obvious ones where...
So can they tell the ink?
Well,
the date of the ink?
We've never had to go down that route. I think it was more obvious than that. There was sort of
tell us what happened.
Different handwriting on there. So I think there were elements of the notes that weren't written up properly. So
and they wrote them up?
After, when the claim came in and we asked for copies of them.
And
but we don't get the originals. We will get copies. So we'll either get a copy via paper or a digital copy.
And what happened in that case?
We asked for an explanation as to why it was modified. Practitioner gave the explanation, but we were going to have to settle the claim anyway because there were other risks. So we settled it.
So we settled it?
Yeah.
Okay.
But we wanted to know why they were doing it.
Absolutely. And roughly the insurance for someone starting off is?
About £580.
That was Vic's question.
£580.
Okay. So we've got some other questions. So
well, I think I've answered a lot of those, if I'm honest. So sort of the extended reporting and...
Yeah.
We talked a lot about claims.
What treatments attract most claims? That would be a good one.
Well, laser, Botox and dermal fillers.
Yeah.
Dermal fillers for 2008 was the highest one. But as I say, they're being done the most frequently, so you expect there to be naturally a proportionate amount of claims. Okay. And anything else you'd like to, we've got people watching here, that, anything else you'd like to say? Obviously insurance is, we're all worried and nervous about, and it's the nature of the industry is it's a very quite a litigious industry.
Yeah. How do we compare to other countries, do you think?
Much lower.
Really?
Much lower, yeah. Litigation abroad is much higher, and the cost, we think the solicitor costs here are a lot. They are much, much more expensive abroad. So from that point of view, we're not that bad, but it is very easy for a patient to make a claim. So it's
easy for patients to make claims.
Always err on the side of caution. Don't take the risk. If you don't feel that the patient's right for the treatment in the long run, although it might be good for business at that particular moment in time, don't take that risk because the claims process and the cost implications of that might outweigh just doing one treatment on a patient. So trust your gut instinct.
Okay. And documentation.
Document, that's my favourite thing to talk about. And don't be pressurised by a patient to do the treatment. So a lot of people say to us that the patient got upset, they were distressed, you wanted to help, and so you felt emotionally like you had to help them out. Those ones are the ones that they say, I knew I shouldn't have done it, and they came back with
And even with family?
Even with family, you need just as much documentation as anybody else. So just because they're a family member doesn't mean that they won't make a claim at some point. And
the last question before we leave is, how many cases actually go to court?
None.
None?
Our main aim is to prevent them from going to court. So last year...
courts...
The cost of going to court is phenomenal.
For everybody?
For absolutely everybody.
So does the prosecution want to go to court?
Sometimes they will issue court proceedings, and then at that point we will decide whether or not we need to settle it or not, or whether we've got a strong enough case to deny. But there's a period of time that you've got to respond to a court proceeding being issued. They might want to because they think they're going to get more money that way, and their costs go up ultimately. Yeah. So it's win-win.
But basically, your aim is to assess it, settle it, pay it, and avoid court.
If it's required to be settled, if we've got a strong enough argument not to, then we will continue down the defence route. But we'll have to get more evidence, so we'll have to get another medical expert or something. Okay.
So that's the sort of medical indemnity side of it. What about your building, your content and your people?
Yeah. So we can ensure all of that as well. So we can make it bespoke to how you're set up. A lot of people don't actually own their own building.
So what happens if I've got a clinic at home? Do I need to be insured?
If your clinic's within your own home, if it's actually within the home, you should let your home insurance know.
Okay.
But if you've got, say, a separate
outbuilding... Let them know I'm
outbuilding...
doing clinical treatment.
Yeah, and your work is a business operation happening, because that will change their conditions. If you have got a cabin, for example, we've got people that have got log cabins in their gardens and things like that, or a separate outbuilding that you're working from, then we can insure that.
Does that have to be... Is that house insurance or separate insurance?
You can do it. Some house insurers will do it, some won't. But we can do it. And we would insure the building, the contents, public liability being the most important. If you've got any employees, you have to have employer's liability by law. So that's another one that needs to be considered. But it all depends on setups, because a lot of people will lease a room within a gym, for example, so they might only be responsible for the contents that they've got in there.
Do they have to be insured for that?
They need, well, it depends on their lease agreement. So some agreements will say they need to take out separate public liability. Others will say that the gym's public liability covers that. Right. So check your lease and just double check what conditions you need to comply with. You can also have cyber liability insurance combined into your medical malpractice. So that will cover you if you have any breach of data, or somebody tries to get into your booking system, for example, and everything freezes.
Has that happened? Do you deal with those?
We haven't had a claim yet. We have got policies, but we haven't had a claim yet. No. We've only been offering that for about 2 years. But our insurers have seen claims.
We had an issue where we got hacked, and they were asked for a lot of bitcoins.
Yes.
Everyone turned up to work on a Monday, and
you can't operate or trade.
None of the computers worked, and we had ransom. Luckily, we had backup.
Right.
We lost a few days, but not very much.
Yeah, so you can get business interruption under that policy as well, so it'll cover for any lost time of trade and reimburse you. So you can have quite a variety of different policies. It just depends on how you set up your business. So if you're not sure and you think you need something else, then talk to us and we can run through it.
Brilliant, brilliant. Well, thank you very much.
You're welcome.
Really appreciate you coming in.
Right.
And how do people get in contact with you, Naomi?
So the telephone number is 0800 634 3881, or you can email us at info@cosmetic-insurance.com.
Brilliant. Thank you very much for coming to see us today.
Thank you.
Great. Good. That was very interesting. Thank you very much. Was there anything else you think we should...